শুরু করে দেবো কি?
হ্যাঁ স্যার, আমি আপনাকে ইন্ট্রোডিউস করে শুরু করে দিচ্ছি স্যার।
ঠিক আছে।
So, good evening, respected delegates. We are really fortunate to have today with us as Chairperson Professor Jyotirmoy sir, who is a professor of internal medicine in Archikor Medical College, and he is a very known national figure. So he is a member and of multiple distinguished organizations, including API, Geriatric Society of India, and there are lots of societies. So he is an WHO fellow. So it is our honor to have him with. So may I request Professor Jyotirmoy sir to take the microphone now. This e-dais is yours, sir. Please.
Thank you, Dr. Shambo, for your nice introduction. First, I congratulate all the delegates and all the speakers, because even in the COVID era, when we are predicting the second wave, we are thinking of the non-communicable diseases like hypertension, because hypertension, whatever may be the communicable disease prevalence is now, hypertension for the round the year for the all country is one of the most lethal disease. Even in the USA, in one statistics, this is seen that more than 50% patients are not on proper medication, either due to non-compliance or due to improper dosing. So uncontrolled hypertension, even in the USA, is more than 50%. That leads to lot of cardiovascular mortality and morbidity. So hypertension management, particularly in different substrate, what I'll do, what medicine I will give, what should the target in PVA, what should be the target in diabetic patient, what should be the target in chronic kidney disease patient. This is very important. So today's seminar by E-Hypertension Academy is a time honored session. I congratulate the organizer to have such a session, and all the students who are delegate in this webinar will be benefited out of this. For the first session, I invite Dr. Partha, who is very well-known speaker to all of us, particularly in the API and IMS circle. He is the professor of neurology from Liverpool, UK. But most importantly, he is the ex-student of Calcutta Medical College. He is senior to me. I request Dr. Partha Karmakar, please give your deliberation and your experience in managing hypertension in CVA patients. Dr. Roy, please.
Thank you. Thank you very much. Namaskar, Shobaike. Namaskar to all. I'm a respected chairperson, Professor Jyotirmoy, respected co-faculties and other speakers, respected members of the audience, dear postgraduate students and friends. I'm very grateful to Dr. Shambo, Samrat, Samajdar for raising a very important issue of hypertension and its interface with stroke. It's a world health problem, as Professor Pal just now mentioned, and I would like to give it a neurologist perspective. Naturally, the topic has got two parts. One is the blood pressure, understanding pathophysiology, and how it impacts on stroke, a major disabling cause for morbidity and mortality internationally. With blood pressure, there is the problem of prevention, treatment during the acute stage of stroke, and secondary control of hypertension. Lots of confusion exists as to the targets for blood pressure, and these are changing. So I hope to finish in 20 minutes time. I will try not to rush because I would like to send the right message for practitioners, as I learned quite a lot in the last 2 days that Dr. Samajdar gave me this topic to research and present to you the most recent findings. So I first looked at the Indian guidelines on hypertension published by Siddhartha Shah et al. In the Journal of Human Hypertension, I think it's important that we understand the readings of 140 or over 90 and above as being the diagnostic cutoff point for blood pressure. But again, I will address the debates that surround it. There are also additional issues of home blood pressure monitoring and ambulatory blood pressure monitoring, which have got clinical relevance, where the cutoff points, as you see, are lower than the 140/90 cutoff. I encourage my patients, in fact, in my own village, I come from a small village in Birbhum, I have been distributing digital meters, and they are all accurate. But there is also a misconception among the public as to whether that's recording correctly or not. Because I found that the prevalence of hypertension undiagnosed, and hence hypertension is the unknown killer causing morbidity and organ damage in a large section of population all over India and globally, being avoidable through these new gadgets that we have. They must see a doctor, of course, if their blood pressure is about 130/980. And that's what the cutoff point I use. And you see the problem of hypertension in India. It's 30%, of which about 35% in urban areas and rural areas having about 28%. And see the compliance rates, as Professor Paul was mentioning at the beginning, 20% in urban, 11% in rural. So it's a huge problem, a public health problem, which is remediable. It's correctable. There is a lot of drugs, and there are lots of protocols, and drug protocols change. I'm not going to go to that in detail, but I'd recommend that all of you read this particular paper, because I read it and I learned quite a lot from it. There are some specific features of hypertension in India, and I enumerate them, whereby you can see how it starts earlier. This is compared to the Western data, and I've been encouraging everybody to develop Indian data, because I left home, my Kolkata, in 1994, and I've been missing it ever since. So I think we should have our own data instead of quoting American data. Not that it is wrong, but because it doesn't apply to the population, which is our target, which is we treat Indians relying on Western data. It cannot be correct. There will be errors if we do that on an ongoing basis. But you can see hypertension in India has got certain special features. Going on with the other guidelines, I have enumerated them just as an ad memoir. If somebody's taking pictures of these slides, you're welcome to. But let me crack on in the interest of time. Just wanted to highlight that whether diuretics or beta blockers are considered first line or second line in the Indian population, whether we want to adopt 130/80 as the cutoff point in patients with coronary artery disease and heart failure. And certainly for recurrent strokes, I personally treat on 130/80. So whether we treat under 60s using that as the cutoff point, what do we do in the elderly? These have all been covered very nicely, including heart failures with normal ejection fraction and with reduced ejection fraction. So this paper is worth the read to practice evidence-based medicine. And going on, you can see out here, I have just identified the risks of hypertension that exist. Doubling of risk for every 20/10 millimeters of mercury. 135/85, if it rises twofold, then it fourfold. So it's quite an exponential risk that we accrue if we do not target blood pressure, which we can treat and manage very well and avoid complications. Europeans, England certainly goes on 140/90 still, but there is a shift towards more aggressive management using the right targets for every country. The second point is strokes. Now, I'll be presenting some data to you about the prevalence of strokes in India compared to the West, but we need to have Indian stroke-based registries. And stroke is not a neurological disease. It's basically a problem for general medicine, for general practitioners, for everybody should be able to treat strokes correctly. And if you look at, this is the hospital from the ICMR data again, National Stroke Registry Program that I have put up here. And if you look at the stroke centers where this registry is basically working out of, there's only Kotak and Odisha around here, then there is Banaras, then there's Delhi, there's Rishikesh, and there is one in Assam, and then further down. So you can see how few and far between the stroke centers are there for optimum management of evidence-based stroke for patients. So that needs changing. And now I am presenting you some data as to what is the current, this is from the ICMR website again, of the stroke incidence per year adjusted for lack of population, and the death rates per stroke, and the new strokes every year in India. And you can see every year in India, we are sort of accumulating the same number of stroke survivors that are there in the UK. So it's a huge burden. And I was speaking to Rohit Bhatia of the Indian Stroke Association from All India Institute, Delhi. It's a stroke epidemic we have been talking about since 2016. So we need to correct it. And that's the stroke statistics from USA. Possibly Professor Pal was referring to it. And you can see how common stroke is and what is the huge amount of social cost and the cost to society that arise out of stroke sufferers. There's also an ethnicity difference in the stroke, nearly twice as high for blacks as for whites. Again, India population-wise has got lots of genotypes, and we'll be discussing hopefully some genotypic evidence as part of atherosclerosis. So there is a lot of subdivisions within the population subtypes within the Indian subcontinent that will have a clear bearing on atherosclerosis and the stroke risk. We have out here some population prevalences. This is 2005 data, long time ago. I'm sure it's no better, but we have to make it better. Now, if we believe that only neurologists should be looking after strokes, then we're never going to solve the problem. This data is from some time ago. There is at the present moment from the Indian Academy of Neurology about 2,000 registered neurologists and 2,700 total neurologists accredited. But it's a general medical problem. Everybody should be able to deal with strokes, which are hypertension and all the rest of it. Amount of imaging in the country, again, is too low compared to the needs, because imaging is mandatory for the optimum management of stroke. And you can see that we are not imaging enough number of people. I was also looking at the Asian subtype of strokes and just highlighted some issues about the diastolic blood pressure being a very great determinant compared to the systolic blood pressure only in the West. But diastolic blood pressure and surges of blood pressure by 55 millimeters of mercury has a 3-time higher risk of strokes compared to who do not have that. This continuous bombardment of the cerebral vasculature, including nighttime surges, diurnal variations, morning surges, and needless to say, hypertension is the main risk factor for stroke. So why are we talking about the cerebral perfusion? Because there is a window of opportunity in the first 4.5 hours where there is a concept called a core tissue, and I will show you some pictures, and a ischemic penumbra. It is very strategic time, 4.5 hours, because neurons are dying at a very fast rate. By the time the patient comes to diagnosis, the core has suffered irreversible damage. But there is an ischemic penumbra I want to target, where if I keep the blood pressure low, then there will be a problem in causing the stroke to extend. If I cause too much of blood pressure rise, then I will be possibly causing hemorrhage into the new infarcted area. So it's a tightrope balance. But would you believe we don't have enough technology, even in so-called Western countries, to manage it? So everything is going on by some sort of guesswork, some sort of randomized controlled trials using end results. What we need to have is real-time available gadgets like a transcranial Doppler to measure the flow of blood within the cerebral circulation. That is still within a research framework. Leave aside the huge mortality, morbidity that will arise if we mismanage the cerebral circulation from stroke. So very important. Now, everybody is familiar of this slide from their physiology days of how in hypertensive individuals, the curve shifts to the right in regards to cerebral autoregulation, which means in patients who have chronic hypertension for 20 years, if we reduce the blood pressure beyond this level, so 120 or thereabouts and lower than that, then it causes a precipitous decline in the cerebral circulation, thereby extending the infarction. And do I know what that patient's cerebral autoregulation is like? I do not. Do I know what the cerebral vasculature is like? I do not, because I've done only a CT scan to show there is no hemorrhage and I'm managing the patient. So I need to do a CTA study, which tells me about the cerebral vasculature. As I was saying earlier on, compared to the West, in Eastern Southern Asia, there is a lot of intracerebral stenosis, which causes a lot of flow deficiency within the cerebral circulation. And we are flying blind to a large extent when we are managing our stroke patients, and hence the outcome tends to differ. Now, this is just a beginning of what I'm going to now lead on to, having talked about the hypertension and the strokes. This you can see is bilateral middle cerebral artery strokes, huge on the left side, becoming bigger. But this established stroke, 1/3 of this area has gone. Here you have a hemorrhage. Here you have most likely another hemorrhage. There is possibly some infarction. I was just trying to find sagittal venous sinus thrombosis with a venous infarction. So all this will present to us as a stroke. We do not use the cerebrovascular accident anymore because everything is treatable and nothing is an accident. We should prevent accidents. So on that note, let me talk about a few numbers now about what to do. So there are 4 types of strokes I'll talk about: ischemic stroke, hemorrhagic stroke, subarachnoid hemorrhage, intraventricular hemorrhage, and I'll touch upon, if time permits, on the venous sinus thrombosis causing a venous stroke, which may be hemorrhagic as well. So basically the guidelines say that 220, 120, just remember these numbers, 220, 120, I'll repeat them a few times. Then 185 over 110, this is when we have to do some thrombolysis. In addition, volume repletion, if the person is dehydrated, then the blood pressure will not be able to maintain the cerebral perfusion. That's another topic I'll come to. And the circulatory volume maintenance. Even simple effects of gravity, when the patient is having cerebral edema and elevated ICP, there is advantage in raising the head end of the bed. Whereas when the perfusion is dropping, just a physical tilting the head by 30% has been shown to increase cerebral perfusion. So there's quite a number of issues that we have to deal with. Here, of course, you're quite familiar with this picture. I put this picture up to just start discussing the ischemic stroke subtype. Here you see the middle cerebral artery, the dense sign. There is infarction developing in that sort of area. You can appreciate how small blood vessels, the lenticular striate arteries, are emerging from the M1 segment, and that's beginning to take out the basal ganglia structures. And this is the aspect score that we calculate to start thrombolysis. Here, of course, everybody is quite familiar. For the PGTs, this is basically your middle cerebral artery, anterior cerebral artery, and the posterior cerebral artery regions of circulation. Here you can see the strokes emerging, the anterior cerebral arteries. And here you can see a sort of, that's the watershed sort of area which will get infarcted, and that's the posterior cerebral artery. Here again, you see the posterior circulation getting stroked out. And again, you have got the cerebellar circulation and the strokes that arise therein. Now, why am I showing you all these pictures? Purely because I said earlier on that we need to do CTA studies to know where the constrictions within the cerebral circulation are. Very important, because then if we lower the blood pressure too much, we'll start getting watershed infarcts in these territories, as you can see, between the anterior cerebral artery and the middle cerebral artery. Perfusion has been reduced by aggressive management of blood pressure because we are flying blind without any transcranial Doppler or without knowing where these stenoses are. And we are possibly over-aggressively manage the hypertension. So these will be the real problems. And that tissue of the brain has gone. So the patient will be left with a Rankin deficit for the long-term future. Now, these are the pictures. This is CT perfusion, computerized tomography perfusion studies. All we get to see these days is basically the infarcted tissue. I want this to be there as well as part of the routine diagnostic workup. And preferably, this is just another 2 minutes of scanning time, which gives us a CTV study, computerized CBV, computerized, blood flow compared to computerized blood volume study. And you can see the difference works out as to where is the core tissue. Because the core tissue is the infarcted tissue, we cannot get blood there. But the big penumbra area is salvageable, and there is scope to get the blood into that area by thrombolysis, by mechanical thrombolysis, by intra-arterial thrombolysis, and then by maintaining blood pressure. Here you see the core, which is infarcted, permanent damage, but all this other area, difference of that versus this is the area that we can easily salvage and get the neurons back, as I showed you in an earlier slide of how the neurons are dying with time. You can read this slide as I can read. The international, first of all, let me show you the thrombolysis, because that's what the main target is. We must try to thrombolize more and more patients with tenecteplase, which is cheaper and is easy to administer. And in my personal experience from a family member having a stroke recently, there was only 2 private hospitals in Kolkata that do thrombolysis apparently. They do not have CTP software, so I could not get that data. And none of the medical colleges, RG Core apparently had some thrombolysis, but it's not happening now. Bangur has it, or had it, I was told. The main treatment for stroke is thrombolysis within 3 hours or 4.5 hours. And that's the blood pressure recommendations, 185 over 110. How to monitor it, it's all there. And with what agents, it's all there. You're welcome to take a picture of this slide and practice thrombolysis for the patients. Should the patient come outside the 4.5 hour window or outside the 6 hour window for posterior circulation, then of course we have to manage the blood pressure differently. And there are cutoff points like 220 over 120, and I've mentioned the indications, and so on and so forth. These are all standard guidelines from the American Stroke Association based upon their patients from the various different thrombolysis trials. Let's shift gears and now talk about cerebral hemorrhages, intracerebral hemorrhages. You can see one there, a big hemorrhage. And just as I was reading a book preparing for this talk, these have got high mortality. 35% of these patients will die in the next 3 months. And even 1 year mortality is quite high. So we must do everything we can to reduce the morbidity, plus make sure that we manage the blood pressure well in the acute stage of the illness. Now here we are entering into certain different numbers. And again, these are the guidelines. You're welcome to take a picture of this slide. So the guideline is that patients who have between 150 and 220, the suggestion is that reduce it to 140. Because if we leave it that high at 220, anything between those numbers, the vessel continues to bleed. If we lower it below 140, then there is that problem of reducing cerebral perfusion and causing an infarction in the setting of a cerebral hemorrhage. So it's a double-edged sword, and hence it's tightrope walking while we are managing hypertension in the acute settings. And there's quite a lot of agents we have, most of them, all of them, I think. I'm not sure about clefidipine, whether it's available, but everything else is titrable in an intensive care setting. So the optimum management of a stroke patient needs to be very real time with regard to hypertension, with regard to intracerebral pressure. I'll come to that in a minute. Here you can see the 2 trials. I thought I'd give you some evidence base instead of guidelines. The 2 trials that have been done in the spontaneous intracerebral hemorrhage and blood pressure management are the ATTACH-2 and the INTERACT trial. And you can see from the underlying statements as to how the data has been difficult to work out, because we are working on the modified Rankin score, which is the stroke outcome data after a period of time. It's a secondary outcome measure. Ideally, we should have data from cerebral perfusions or transcranial Dopplers, which will give us the information real time regarding cerebral perfusion, or we need some biomarkers of strokes. We are still far away from that, but that's the way forward for my junior colleagues and postgraduates to take the research further forward. That's what needs doing. And you can see from the other underlying statement that if we drop it too low, then between 120 to 130, we get favorable outcomes. But then they're having the caveat as to whether these patients had less smaller hemorrhages or less severe hypertensions. So that's a summary slide that shows you what the current recommendations are from the American Stroke Association in managing the second type of strokes, the spontaneous intracerebral hemorrhage. Let us shift gears and talk about one small intraventricular hemorrhage. Here you can see the blood has spilled into the intraventricular third ventricle. Here it's spreading out into the lateral ventricle and into the anterior horn there. So here the guidelines are that the optimum blood pressure management in this situation, we don't have a real guideline to give you. But there is definitely, in this small trial of 48 patients, they found the risk of hemorrhage decreasing. It doesn't increase any further, where the MAP was reduced by 30 millimeters of mercury. So these are, not good quality evidence, but this is what we work on in intraventricular hemorrhage. The guidelines, they're saying that you follow the guidelines for ICH, which is the figure of 140, I'd like you to remember. So far we have had 220, 185, 110, and 140. I've given you 5 numbers to remember for blood pressure, and you know which one matches with which one. I can pass on the slides to Dr. Samrat for dissemination. I'm shifting gears again in the interest of time to talk about subarachnoid hemorrhage. Now that's another cause for stroke in the presentation. You can see how blood has spilled into the perimesencephalic space. All of this is blood, and that's the culprit that has burst and bled. So what is the blood pressure control guideline here? The optimal therapy of hypertension in SAH is not clear. But for most patients, to maintain systolic blood pressure less than 160 and the mean arterial pressure less than 110 is the guideline. You are using nitroprusside, nitroglycerin to be avoided because they might increase cerebral blood volume and therefore ICP. Now, in this particular condition, which is a neurosurgical emergency, here you have to involve neurosurgeons because of the need for aneurysmal management. The cerebral perfusion pressure becomes very important to estimate. Otherwise, you are again flying an aeroplane blind, and you might hit a bird or hit another aircraft or maybe a Martian from outer space. Because here you see CPP equals MAP, mean arterial pressure, minus the ICP. If you don't measure ICP, an ICP measurement is no rocket science. The devices have become much cheaper. For severe subarachnoid hemorrhages, they have to be treated because you see the difference of cerebral perfusion. Pressure is important. And that again is a surrogate marker of what the blood pressure is flowing. In the absence of ICP management, which is where we are, then I think antihypertensive therapy should be withheld unless there is a severe elevation. And here we're using the patient's cognitive status as a guideline. Wake the patient up, do a GCS, and then adjust the blood pressure. So that leads me to the last 5 minutes of my talk, nearly on time, maybe 5 minutes extra. So after having dealt, I have not touched upon sinus thrombosis because it's a coagulopathy mainly. Let me finish up with this as to when to restart the stroke blood pressure treatment for secondary stroke prevention in patients who have come to us with those 4 types of stroke. Well, it should be resumed at different, for TIAs, which is also another mini stroke, and I didn't discuss it because without further delay, we need to get on top of that. Yes, we're finishing now.
Hello.
Ha, Bolun. Yes.
Hello.
Yes, I can hear you. I can hear you. Okay, I think I need to finish now. Yes. So patients with
Dr. Roy.
yes, sir. Bolun. Shunte pacchi. I can hear you. Okay. Right. So let's look at this slide, and I think my time is up, so I should finish now. So just have a quick read. For prevention of recurrent ICH, we need to get a more intensive blood pressure goal and start to treat so that. And how much do we reduce the blood pressure by? Approximately 10% per day, although there is no consensus. With this, thank you very much for listening. Sorry for stepping over by 5 minutes, and all the best to all of you. Let's get hypertension under control and get stroke patients less in number, and those who are, let them get the best evidence-based treatment. I'm happy to share the slides for the PGTs for their understanding. Thank you.
Hello.
আমার শেষ হয়ে গেছে বলা।
Thank you. Hello.
আমি আনশেক এন্ড শো।
আচ্ছা আচ্ছা আমরা ডক্টর শাম্বু আমরা কোশ্চেন আনসার কি সবাই লাস্টে করব?
Yes sir, yes sir.
তাহলে আমরা কোশ্চেন আনসার একেবারে সবাই লাস্টে করি, ঠিক আছে?
Yes sir.
So I am going to the second session, that is management of hypertension in CKD. Speaker is Dr. Vivek Goyel, is a renowned nephrologist. I request Dr. Goyel. Hello.
Yes sir.
Am I audible?
Yes.
Dr. Goyel, please.
You are audible, sir. Dr. Goyel, are you ready now, or you can? There is some issue with Dr. Goyel's internet connection. So,
should I go to the third speaker?
Yeah. So, if Karmakar sir is ready, sir, then we can request Karmakar sir to proceed.
Professor Karmakar, are you ready? Hello. Hello, Dr. Karmakar. Shambo, উনিও মনে হচ্ছে রেডি নন।
Yes, sir was there.
Dr. Shambo, this is Dr. Satinath. Can you hear me?
Yes, sir.
Yes.
I am ready. I have no problem.
Oh, yes, sir. Yes, sir.
Okay, sir.
Yes, sir. So, okay, sir. So, we are starting the fourth session. There is a secondary hypertension and endocrinologist angle. Speaker needs no introduction. He is Professor Satinath Mukherjee. He is the professor of endocrinology from IPG1 SSKM Hospital. Dr. Satinath Mukherjee, please start.
Thank you, Professor Paul, and thank you for allowing me to jump the queue also. So grateful. Now is the tricky part. Sharing the screen. Can you see my, I believe you can see my desktop. So
no sir, still it is, yeah. Now
yeah, you can see, and it's in the presentation mode now, and I think it's, I'm sorry, okay, on the end slide, so give me a moment. Yeah, so there you go. I think it's ready to roll now. Okay, so endocrine hypertension, although rare, is interesting to study because they're potentially curable forms of hypertension. Unlike essential hypertension, where you need lifelong treatment and monitoring without being any possibility for any cure on the horizon. So this takes us to the next slide. Now, although endocrine hypertension has very many causes, almost all are rare. For the purpose of this presentation, I thought I would pick up at least 3: Cushing, primary aldosteronism, and pheochromocytoma. But then again, I thought in the interest of time, it would be better if I focus only on primary aldosteronism in the next 20 minutes or so, the diagnosis of which might be tricky and often missed even in cardiology practice. So I would like to finish my presentation on primary aldosteronism in 20 minutes. And if during question and answer session, people are interested, students are interested to know something about Cushing and pheochromocytoma, I'll be more than happy to take them up. Now, unlike the previous presentation, of which was a very power-packed book-like presentation, here I will just be walking you through two very recently worked up cases at our clinic at SSKM, because what I think is nowadays with the internet and all available, so you can read the guidelines or the text yourself at your convenience, at your leisure, but you may not be able to come across interesting cases in your practice, these cases being rare. So let me start with the case vignette 1. Dr. S.S. is a 62-year-old homeo practitioner who has been self-treating his hypertension for about 5 years or so. He landed up into the emergency of a local hospital at 6 a.m. in the morning on the 3rd of May 2020 with sudden increase in blood pressure. I hope you can see the scribbles. Sudden rise of blood pressure, neck pain and nausea. So after stabilizing him on 2 injections of Zofar and Pan 40, the emergency medical officer put 2 drops of nifedipine liquid in each nostril, and the blood pressure, which was 240/100 at presentation, came down only within minutes to 190/100, and after 5 minutes it was 180/90. So the patient was advised bed rest and to consult a cardiologist ASAP. He was put on telmisartan and amlodipine, and since he was obviously anxious for this sudden increase in blood pressure, so he was put on alprazolam as well. The medical officer also prescribed a CT scan. A CT scan unqualified, I think, means CT scan of the brain, an ECG, and that was it. So Dr. SS did not waste any further time and consulted a local MD cardiologist on 6th of May, when his blood pressure was found to be 120/80. So the cardiologist did an ECG which showed sinus tachycardia with right band branch block. The CT scan of the brain did not reveal anything. The cardio also documented that the patient was on SSRI and for the last 6 months, and SSRI was prescribed because the patient had suffered a transient ischemic attack leading to transient right hemiparesis 6 months ago, apparently owing to a hypertensive surge, following which, being a practitioner, medical practitioner, he got somewhat anxious and depressed, and he was prescribed an SSRI. But then since the blood pressure came under control, amlodipine was taken off. As you can see here, the patient was put on telmisartan 40 milligrams a day. And since the ECG showed sinus tachycardia, so nebivolol 2.5 was added. But the BP did not come under control. And after a week or so, the blood pressure being 180/110, And by the way, the patient records his blood pressure every day, morning, evening, being a physician himself. So he consulted a second cardiologist, a DM cardio this time. And as you can see, the ECG interpretation, PR interval of 156 milliseconds, QRS interval of 59 milliseconds, and nebivolol was replaced by propranolol, and the DM cardio added 10 milligram of cilnidipine and also chlorthalidone 6.25. He asked for a serum sodium potassium and creatinine, and also told the patient that it's good to have a BP target below 130/80. With this, the patient went back home, but the blood pressure was not controlled. On 2nd of July, his home BP was 170/95 in the morning. So he called up the cardiologist number 3, another DM cardio, and fixed up an appointment in the evening. When at the cardiologist's clinic, the BP was 160/90. And by this time, creatinine report was available, 1.5. So it was chronic kidney disease possibly. And the potassium, as you can see, was 3.1. So hypokalemia. So this time, the treating cardiologist anticipated that the patient might be having a combination of hypertension and hypokalemia. So he stopped, as you can see, chlorthalidone, and stopped telmisartan also, because that might interfere with the estimation of serum aldosterone and plasma renin activity. So put the patient on an alpha blocker, the combination of bisoprolol and amlodipine, and asked for a Doppler of the renal arteries to rule out renovascular hypertension. The Doppler revealed nothing, and he also advised a CT scan of the kidneys and adrenals, which revealed a 1.5 into 1.4 centimeter hypodense nodule in the left adrenal gland. With this, the patient was referred to to see an endocrinologist, and that's how he landed up into our clinic. So at the first visit, his blood pressure was 171/89 on 3 antihypertensives, serum creatinine of 1.7 with an eGFR of 30. And this time the potassium went up to 3.5 following stoppage of chlorthalidone. Now serum aldosterone level was done, and it was 14.1, more than 10 being abnormal, with a suppressed plasma renin activity of less than 0.1. So the screening test was positive for primary aldosteronism, and there was an adrenal lesion in the left adrenal. So we had this combination, but then going by guidelines, you have to confirm the diagnosis with a saline suppression. Now, this patient being significantly hypertensive and also having CKD, we discussed with him the hazards of saline suppression. He refused. And then because the eGFR was low, we could also not subject him to adrenal venous sampling to confirm that the adrenal nodule, in fact, was the culprit lesion causing his primary aldosteronism. So the patient preferred to go for long-term medical treatment. So we shifted him to verapamil, which is kind of aldosterone neutral calcium channel blocker. So 40 TID, then prazosin, we continued 2.5 twice a day, and we added a selective mineralocorticoid receptor antagonist, i.e. eplerenone 25 milligrams twice a day. So after a week, as you can see, his creatinine came down to 1.4 and his potassium normalized to 4.6. Then on second visit, about 2 months later, 3 months later, the blood pressure was then normal, 126/75. he continued to have tachycardia, so we added metoprolol. He was having some problem with eplerenone in the form of fatigue and the gastric intolerance, some insomnia. So we removed eplerenone and then put him on spironolactone, although it's not the first choice mineralocorticoid receptor antagonist in male subjects with primary aldosteronism because of their non-selective nature. Because of their non-selective nature, they can give rise to low libido, erectile dysfunction, gynecomastia. Anyway, he tolerated spironolactone well, and his creatinine now came down to 1.6, and the eGFR improved to 53, and the potassium level was still being maintained at 4 millimoles per liter. On third visit, which was about 4 months from the second one, he was maintaining his blood pressure. Now the pulse rate was 56, and the patient also reported that he felt that metoprolol was possibly not having any effect on his blood pressure control, so metoprolol was discontinued. Currently, the patient is on spironolactone 100 milligram twice a day and prazosin XL 5 milligram nocte. And just before this presentation, about half an hour ago, I called up Dr. SS to know how he has been doing. Since his last consultation, he said, I'm doing fine. Today, his blood pressure is 130/76 with a pulse rate of 84. So this cartoon shows you how his eGFR has improved over time. So chronic kidney disease in primary aldosteronism is not commonly seen in the West because of increased awareness. The cases are picked up early, but it's not an uncommon situation in India at all. Many a time, in fact, most of the time, the cases of primary aldosteronism that we see, they come to us with chronic kidney disease, and that confounds the clinical scenario. But fortunately, in this patient, with treatment, his eGFR almost normalized over a period of 6 months or so. This cartoon shows you how nicely the creatinine has gone down and the potassium has normalized over time. The blood pressure has been under good control since last 6 months with spironolactone, and which is a clue that the patient is actually having aldosteronism as a cause of hypertension. He was on 4 antihypertensive agents, not controlling his blood pressure, with currently on only spironolactone and a touch of alpha blocker. His blood pressure is under good control. So now this brings us to the case Vineta 2, which is a 42-year-old chemistry teacher suffering from resistant hypertension, which developed following her only childbirth about 12 years ago. Then on addition of a diuretic thiazide to her regimen, which was the 4th drug to be added on to telmisartan, amlodipine, and alpha blocker, she started having fatigue and recurrent hypokalemia causing muscle weakness. Then she was started on spironolactone by a cardiologist who found her to be hypokalemic and removed the thiazide. While she was not referred to an endocrinologist, she did some Google search and found that a combination of hypertension, hypokalemia called for an endocrine consultation and landed up into our outpatient at SSKM. But in the meantime, with addition of spironolactone, she felt better. Her blood pressure came under control, and potassium level also went up. So while under endocrine evaluation, her creatinine was normal. Spironolactone was stopped, as you have to do that for at least 6 weeks if you are to evaluate a patient for primary aldosteronism. Her blood pressure was controlled like in the previous case with a combination of verapamil, prazosin, and this time hydralazine was added. Serum potassium was normalized to 4 with addition of pot chlor. After 6 weeks, plasma aldosterone was 37.8 nanograms per deciliter, on the cutoff being less than 10, and the plasma renin activity was completely suppressed. A CECT of the abdomen revealed 11 by 6 millimeter hypodense left suprarenal nodule. Now, again, this lady is having primary aldosteronism. The screening test is positive. So the question is, should we go for a saline suppression as is mentioned in standard international guidelines? Well, there is an exception here. If the patient has marked hypertension, symptomatic hypokalemia, and a severe aldosteronism with aldosterone level more than 20, you really do not need a confirmatory saline suppression test. Now then, as per guideline, if the patient is more than 35 years of age, before subjecting her to adrenalectomy, you need to do an adrenal venous sampling. So when we discussed adrenal venous sampling with the patient with potential hazards and the potential invasive nature of the test, the patient refused a venous sampling and chose to go for a laparoscopic adrenalectomy, for which she has been scheduled, and her operation is going to take place next week. So after sharing these two case scenarios, let me quickly summarize the current guidelines on primary aldosteronism. I request Professor Jyotirmoy Pal to raise a red flag as soon as my time is up, because I have covered the case presentations which I thought was important. Well, so if you get a severe resistant hypertension, which is defined as blood pressure more than 140/90 on 3 medications, or less than 140/90 on 4 plus medications, hypertension plus either spontaneous or diuretic induced hypokalemia, then hypertension and an adrenal mass, or a sleep apnea, hypertension and family history of primary aldosteronism, and finally hypertension with stroke in the young, history of stroke in the young in the family, less than 40. So how to screen? You have to put the patient on neutral BP medications, i.e. alpha-1 antagonists like doxazocin or razocin, and hydrazine and verapamil. So marked hypertension is more severe and more resistant to control in aldosterone producing adenomas rather than on idiopathic adrenal hyperplasia in the between third and 6th decades of life. Unlike in causes of secondary aldosteronism, such as chronic kidney disease, chronic liver disease, and chronic heart failure, edema is conspicuously absent in primary aldosteronism because of a phenomena called mineralocorticoid excess. I cannot discuss the details in the interest of time. So marked hypokalemia may lead not only to muscle weakness, cramp, polydipsia, polyuria, but can also give rise to new onset diabetes, because hypokalemia interferes with insulin output from pancreatic beta cells. Periodic paralysis is frequently seen as a presenting feature of primary aldosteronism in Asians, but not so common, rather rare in the Caucasian population. Around 70% are normocalemic. So hypokalemia becomes evident only after starting a diuretic, and normocalemiia is becoming more and more common because of increasing the use of ACE inhibitors and ARB that kind of jack the potassium levels up. The CKD, like I said before, is commonly associated with primary aldosteronism as a confounder in India because of late detection and lack of awareness. So when to consider testing for primary aldosteronism, well, as per the current Endocrine Society guideline, all hypertensive patients should be screened for primary aldosteronism at least once in their lifetime. And if you do that, you may be able to pick up around 0.5 to 1% of those patients having primary aldosteronism. Then you sample them with a so morning blood sample, plasma aldosterone concentration and plasma renin activity. you no longer depend on the ARR or aldosterone renin ratio. You look at the absolute values. If plasma aldosterone concentration is more than 10 and the PRA is less than 1, your screening test is positive, and then you confirm with a saline suppression. So you infuse intravenous normal saline 500 milliliters per hour over 4 hours with in a patient in the sitting posture, although recent studies have shown that you can do sample the patient also while supine, so the accuracy is maintained. Now, at the end of saline infusion, if the aldosterone level is less than 5, primary aldosteronism is ruled out. If it is more than 10, PA is confirmed. Between 5 and 10, this is indeterminate and mostly seen in patients not with aldosterone producing adenomas, but with idiopathic adrenal hyperplasia. I think I'm almost coming to the end of this presentation. So the treatment principles are not only to control hypertension, but also to control hypokalemia and normalize aldosterone level, because excess aldosterone can cause myocardial fibrosis and cause cardiomyopathy in the long term and increase cardiovascular mortality. And that's why surgical normalization of aldosterone producing tumors is the treatment of choice. But if surgery is not feasible or the patient refuses surgery, one should try to normalize aldosterone level and plasma renin activity with optimal use of mineralocorticoid receptor antagonists. Unilateral laparoscopic adrenalectomy is the treatment of choice. So soon after surgery, in the next day or so, actually aldosterone level normalizes and there is biochemical cure. While preoperative hypokalemia correction is mandatory, potassium infusion and use of mineralocorticoid receptor antagonists has to stop immediately post-op, because there can be dangerous hyperkalemia. And because of suppression of contralateral adrenal cortex, so persistent hyperkalemia for up to 4 weeks is not common. So the patients should be undergoing weekly monitoring with serum potassium levels. So the take-home prevalence of primary aldosteronism is much higher than classically or previously recognized. And that's why the Endocrine Society now recommends that all hypertensives should have a screening for primary aldosteronism at least once in their lifetime. Renin-independent aldosteronism, which is not suppressible, is the clue. So forget about primary aldosteronism. If you see that the plasma renin activity is normal, never ever screen those patients for primary aldosteronism, no matter how high the aldosterone levels are. Beware of factors that may result in false negative screenings, namely medications that increase renin levels, like ACE inhibitors, ARBs, and the mineralocorticoid receptor antagonists. Beta blockers falsely elevate plasma renin activity. They may give rise to false positives. Localization studies in the form of imaging and adrenal venous sampling should be considered only once a biochemical confirmation is made with saline suppression, but the exception being a patient with marked hypokalemia, severe aldosteronism, treatment-resistant hypertension, where a saline suppression is not essential as a confirmatory test. You can go directly for adrenal venous sampling if the patient's age is more than 35, or straight away for adrenal imaging for confirmation of aldosterone-producing adenomas. This brings us to the end of this presentation. Thank you for listening. Over to you, Professor Pal and Professor Dr. Shambo.
Thank you, sir. Thank you very much. I am Shambo here. Jyotirmoy sir most probably getting some issue in his internet. So from the forum of Inovocare, I express my thanks to you, sir. So I request all the delegates to put their question in the chat box. We can ask sir later, or sir can ask in the, and give the answer in the chat box also. So may I request Professor Partha Sarathi Karmakar sir now to come up, and sir, we all know sir needs no introduction. Sir is now Professor of Internal Medicine in Arjikor Medical College. So, sir, now this EDAS is yours, sir. So may I request Satinath sir to unshare the screens, please.
Thank you, Shambo. I'm starting.
So, yes, sir. Now you can share your screen, sir.
Yes, sir. Can you see? Can you see my desktop?
Still not, sir.
Hello,
Still
Shambo?
not, sir. Sir, you have to click on that share. Yeah, it is now coming, sir.
Can you see?
Yeah, it is coming, sir. Sir,
Is it full screen now?
yeah, full screen
Yes,
now.
Dr. Karmakar, please start.
Okay. Thank you. Good evening, everybody. Respected Chairperson, Dr. Professor Jyotirmoy Pal, my good friend of mine, co-faculties, and all the whole organizing team, especially our Dr. S.S. Samajdar, that is Shambo Samajdar, for giving me this chance to have a talk on a very important topic, that is monitoring of BP in office and home. ABPM, ambulatory blood pressure monitoring, a cardiologist concern, rather I will call it internist concern, because majority of blood pressure first time come to our internist for getting it controlled. So I'm thankful to all of them for giving me this chance to have a talk in front of such a learned gathering. So I will try to cover the topic through briefly touching upon the following points, that is introduction, burden of hypertension, importance of reaching goal BP, categorizations of hypertension, and importance of ambulatory blood pressure monitoring, 9 deepers, how it is important in ambulatory blood pressure monitoring, and take-home message. So we all know, in my preamble, I like to highlight some known facts, but it's very important to keep in mind whenever you are coming across a hypertensive patients for getting it controlled. So blood pressure or circadian variations is definitely there, but it is not a constant. It is not constant throughout 24 hours. Not detected, and this circadian variation cannot be detected in clinic BP measurement. And availability of home and ambulatory blood pressure measurement techniques can help us to detect whether there is how much circadian variations is there. Definitely detection of circadian variations through through home blood pressure monitoring and ambulatory blood pressure monitoring, and its fluctuation can also be jolly well recorded. And here lies the role of importance of home blood pressure monitoring and ABPM, and it is really getting it has gained its ground in last 1 or 2 decades and getting more and more important so far proper blood pressure control is concerned. And BP fluctuations variability, that is circadian rhythm, are known since 19th century. And you will definitely be, many of us may get astonished to know that it has been said by Scipione Rivarossi, which is inventor of modern mercury sphygmometer. He said way back in 1896, that is more than 20 years back, he said that it is enough to speak to the patient, invite him to read or look at him suddenly, or perhaps it will take a sudden noise a carriage going past in the street, and a shout of loud but distinct noise to make the blood pressure rise, and not necessarily to the same extent in all cases. So any sort of distraction can lead to blood pressure to rise. And another important thing, although it is not the only factor, the simple applications of the instrument can cause, that is the whenever you are keeping the blood cuff on the upper arm, that is simple applications of the instrument can cause a temporary rise in the blood pressure. So it is therefore necessary to take not just one reading, but several in succession to get the true BP of that very particular person. So it has been said in 1896, still many of us, depending upon, due to our busy schedule, not on the proper way, but depending upon the single measurement of blood pressure, and come to a conclusion whether the patient is hypertensive or not. So that is actually wrong, and that has been depicted much back, that is in 1896. So majority of hypertensions are really not coming with any symptoms. So that's why, but you know that hypertension is one of the most important cause for even mortality. So that's why hypertension is considered to be a slow, silent killer. So far the guidelines is concerned, how blood pressure is being categorized. So before coming to the categorizations, we all are aware of JNC 7 that was published in 2004. And this is still today very much, very much popular. So far the blood pressure control is concerned. And we all know, just for recapitulation, because banking upon these classifications, the other recent classifications has been modified. So we all know that we consider a normal BP below 120 by 80. But if it is within 120 to 40 and 85 to 90, it is considered pre-hypertension. And then stage 1 hypertension, 140 to 159 and 90 to 99. And if it is above that is systolic blood pressure more than 160 and diastolic blood pressure more than 100, it is called stage 2 hypertension. Though in UK, they considers another, that is stage 3, above systolic 180 and diastolic 110, that is stage 3 hypertension. So how do they differ, the JNC7, the SSC and AHA that came forward in 2017, JNC7? They have divided, I have just said that the pre-hypertension in 120 to almost 140, that is 139, and diastolic blood pressure, if we consider 80 to 89, they have divided into two halves. Both JNC as well as the ISA, that is International Society of Hypertension, that has been published in 2020, the recent most hypertension guideline. They have just pre-hypertension stage of JNC7 divided into two halves. Early half, that is 120 to 130, and the later half, that is 130 to 140. So how they modified? They have modified in JNC 7 and JNC 8. They have the early half, they have considered as elevated BP, that is the last column, elevated BP, and 130 to 129 they have considered as stage 1. And the stage 2 hypertension of JNC is stage 2, and stage 2 is also stage 2 here. So stage 1 hypertension, what was the later half of pre-hypertension in JNC 7 is considered stage 1. Above that, everything is stage 2. That way, they have come down so far whole BP is concerned. Similarly, the International Society of Hypertension that was published in 2020 January, they have also come up the first half of JNC 1, that is up to 130, and diastolic up to 85. They have considered into normal BP, and the later half they have considered not the stage 1 as like AHA, ASA, but they have considered is high normal BP. And grade 1 and grade 2 hypertension is like that of stage 1 and stage 2 hypertension. So for hypertension categorization is concerned, ISH and ISH as well as ACC and AHA, both are similar. Only the first half of pre-hypertension of JNC has been divided in a modified way. So what should be the goal BP? So far our different guidelines is concerned, according to JNC, it is below 140 by 90. In AHA, ASA, that is American Society, that is in 2017 below 130/80, and according to International Society of Hypertension in 2020, they have said the goal BP should be less than 130/85. So why they have come down from GNC7 140/90 to 130, 135, 130 to 135? So because they have come down to 10 millimeter mercury systolic reductions as well as 5 millimeter mercury of diastolic reduction, because of one thing, because they have shown that significant reductions of cardiovascular events by reducing target BP by 10 millimeter mercury of systolic and diastolic level from the conventional 140/90, you can reduce significant amount of cardiovascular morbidity and mortality. That's why goal BP has been reduced from 2017 to 130/80 or 130/85 in ICH. So hypertension in India, what is the burden of hypertension in India? The burden of hypertension in India is mammoth. It has been shown in 2018 that it was 118 million of people are hypertensive, and it is almost going to be double in the year 2025. So by 25 years, that hypertensive populations in India is getting doubled from 118 to 213 million. So just try to remember, guess how much burden of hypertensive patients in India that is really increasing. So if we can, why we have brought down the goal BP by 10 millimeter of mercury, we are very much fussy regarding that thing, because anti-hypertension therapy, and if we can reach the goal, that is according to ICH below 130 systolic, 135 systolic and 85 diastolic, we can achieve mammoth amount of benefit in the form of stroke incidence reduction by 35 to 40%, myocardial infarction reduction by 20 to 25%, and heart failure reduction by to the tune of more than 50%. So I remember it 40, 20, and 60. So 20% reduction of MI, stroke reduction 40%, and heart failure reduction to the tune of 60% just by control of BP. Forget about the other risk factors. So mammoth benefit you can achieve just by controlling blood pressure of the patient. But the tragedy of this rule of halves, rule of halves, what is what that says? Even in UK, or Western countries, developed countries, they have said that out of 100 blood pressure hypertensive patients, only 50% of unaware, because I have told in the very initial part of my talk that is majority of them even asymptomatic. So 50% of them being asymptomatic, they are unaware that they are hypertensive, and those who are aware, 50% only they see doctor for therapy, and 50% of them after getting therapy, only 50% of them receive proper therapy, and 50% of them who are getting product therapy are controlled. So ultimately, out of 100 hypertensive patients, only 10 to 15% of the hypertensive patients are reaching the goal BP. So such is the sorry figure. So for control of blood pressure is concerned, and so reliable blood pressure measurement, whether that 10 degree from 142 we have been able to achieve 130 or not, or from 90 diastolic blood pressure we have been achieved to below 85 millimeter mercury or not. So reliable BP measurement is the most important part, whether it's a clinic BP or through ambulatory BP or home management. So position of the patient, as well as the cuff length, as well as its weight, and patients should not be with smoking or any hot beverages within half an hour. So I have shown in the cartoon the proper position of the patient. Arm is semi-flexed and back is rested quite comfortably, and foot touching the his foot is touching the ground. So that you all know. I'm not going into details of that. So after getting proper measure, after properly measuring the BP on that occasion, that is not the true BP, because you have to have average of at least 2 or more readings on 2 and more office visits or clinic visits. You try to go for average of all these blood pressures, and that only give you almost near to true office BP, OBP, that means office BP. So if you are seeing that there is too much fluctuations of office BP measurement, what you should do. NICE guideline has come forward with a very important practical guideline if you go by office BP, because ambulatory blood pressure monitoring is not possible for all patients because it's a little bit costly investigation. So if you see blood pressure more than 140/90, go for second measurement. If it is substantially different from 140/90, then go for the third measurement. And lower blood pressure of last two measurements, forget about the first measurement, last two measurements is the lower BP is your office BP, almost that is reflector of true BP in majority of patients. So you have to go for 3 measurements at least to come to our office BP on 2 or more visits. So so we have now given importance to, so far guideline is concerned, out of office BP measurements provide clear picture of usual blood pressure for accurate diagnosis and management. So out of office BP measurement is much more near the goal BP, near the true reflectors, being the true reflectors of BP compared to office BP measurement. So after getting the BP, possibly on 2 or 3 occasions, getting the according to NICE, you are going by the NICE protocol and you are getting the lower of the last 2 measurements. Still, you have to categorize that BP to 4, and I have written into 4 square. Wow. So you can get true normal tension, all the time you are getting blood pressure below 130/85, or all the time you are getting blood pressure more than 135/85, or after these two, sustained hypertension and true hypertension, there are 2 tricky things or gray zones. Patient may have white coat hypertension, which may mimic sustained hypertension. Or patient may have masked hypertension, that is, whenever patient is coming to your clinic, patient is showing normal BP, but out of office clinic, that happens almost in 11 to 15% of patient out of office, they are really having sustained hypertension. So this masked hypertension and white coat hypertension, these 2 tricky effects so far the office BP measurement is concerned, to know whether patient is really hypertensive or normotensive, you have to go by ambulatory blood pressure monitoring. So here lies the importance of ambulatory blood pressure monitoring. So what is the limitations of clinic BP measurement? The inherent variability of BP, that is circadian variability of BP, coupled with the same number of breathing. So you need to go for 3 or more blood pressure measurement in your clinic. The white coat effect, that is the increase of BP that occur in the medical care environment, and the masked effect, that is a decrease of BP that occurs in the clinic, but out of office they show much higher blood pressure. So and you can have error. So far human error is always there. Your measurement can be a little bit away from the proper protocol, and you may falsely show raised or lower BP. So indications of ambulatory blood pressure monitoring is suspected. Whenever you are suspecting that patient is showing hypertension due to his alerting conditions or little bit transient adrenaline secretion while they are coming to your clinic. So suspected white coat hypertension needs ambulatory blood pressure monitoring for getting the true blood pressure. Similarly, suspected masked hypertension is also indications for ambulatory blood pressure monitoring. Suspected nocturnal hypertension is sometimes can give rise to whether patient is having nocturnal hypertension or not, why patient is on sleep, needs ambulatory blood pressure monitoring for its detection. And hypertension despite appropriate therapy, you are putting patient's compliance is already maintained, and you are putting patients on 2 or 3 drugs, but patient's blood pressure is not controlled. And patients with high risk of future cardiovascular events, even if clinic BP is not normal, but patient is showing that there is so many cardiovascular risk factors. So you should go by ABPM, whether you are dealing with a masked hypertension or patient is really carrying a risk for that. And suspected episodic hypertension, patient is sometimes normotensive, sometimes hypertensive, you should go. That is also an important indicator for ordering patient to go for ABPM. So ambulatory blood pressure monitoring may also be useful for titrating, apart from the indications I have just depicted, the titrating antihypertensive therapy to follow up patients ABPM may be sometimes very much helpful. Borderline hypertension, whether patient is having borderline hypertension or true hypertension, and along with other things, that is hypertension detected early in pregnancy, whether patient is to be put on, whether she needs to be put on some antihypertension or not, you should go by ambulatory BP before putting patients, because all sorts of medicines to be avoided until only in pregnancy, until and unless it is mandatory. So that is the common dictum. As suspected and confirmed sleep apnea along with syncope or other symptoms suggesting orthostatic hypotension, there is suggestion of orthostatic, you are suspecting, and to detect it confirmedly, you may have to go for ambulatory BP monitoring. So white coat hypertension or newly detected Indian hypertensive patients, it has been shown that in some Indian studies, as Dr. Partha already recommended, that we have to go by Indian studies. So I have put forward here some Indian studies. In Indian study, it was shown that 55 asymptomatic ARQ was taken, and 37 of the patients showed that they are having, whenever they are coming to clinic, they are showing blood pressure above normal, that is more than 140 by 90. And ultimately, they were not being recruited in as professional worker over there in civil pilots or military aviators. So they went for ambulatory blood pressure monitoring, and it showed that 35%, that is 35 out of that 55, that is 63%. It's not as though that 63%, that is almost 2/3 of persons, showed that they are having only clinic BP or white coat hypertension. Whenever they are going by ambulatory blood pressure monitoring, they all showed that they are really within the normal blood pressure range, and they were recruited ultimately. So what is the definition of ambulatory blood pressure monitoring? You all know it is nothing but the automated measurement of blood pressure during a 24 hours period while patients engage in their usual activities, including sleep. So that is the most important part, including sleep, because during sleep also that ABPM is being recorded. That is the difference between HBAPM, that is home blood pressure monitoring, and ambulatory blood pressure monitoring. Because home blood pressure monitoring, as patient is measuring in his own residence, it is not possible to record why he is having his sleep. So white coat hypertension out of office BP, that is whenever it is 135 by 85 below and no target organ damage. So when do we call a patient is having white coat hypertension? Patient is showing BP above 140 by 95, or according to International Hypertension Society of 2020, in the year 2020, it shows blood pressure above 135 by 85. But whenever out of office blood pressure is being measured, it is below 135 by 85, and it doesn't show any target organ damage. So target organ damage in relation to either central nervous system or cardiology or kidney, something like that. It could be subclinical as well as clinical. So ambulatory BP, that is either home BP, I have already shown how it differs from ambulatory blood pressure. Always, whether it is HBPM or ABPM, it is almost always less than clinic BP, except masked hypertension, which can happen in 10 to 15%. Because masked hypertension, they show normal blood pressure in office BP, but whenever they come to their home environment or in their office, they show hypertension. So in this one very important point that should be remembered by the treating physician, that masked hypertension is always carry, unlike that of white coat person, always carry increased cardiovascular morbidity and mortality. White coat aggravation, what is that? Because whenever patient is coming to, we know that patient is hypertensive, patient is already on therapy, and whenever patient is coming to your office, it shows 15 to 20% of patients show that their BP is not controlled. If you go by ambulatory BP, it shows that all those 15 to 20% shows BP less than 130/85. So in 15 to 20% of cases where you were thinking that you should increase the patient's, you should start therapy of that patient of that patient by ambulatory blood pressure monitoring, you can prove that patient doesn't need any therapy. That is the white coat aggravation. And another important thing, whenever patient is already on treatment, 1/3, that is almost to the tune of 30% of treated patients, they show increased BP. That means we are coming to a decision that patient, that medicine is not controlling that patient's blood pressure properly. But if you go by ABPM, that majority of 30% which show office BP high than goal BP shows there is adequate or even excessive control whenever you go by ABPM. So you are really avoiding in 1/3 persons, almost 30% of patients who are being treated with some medicine, they are either adequately controlled or excessive control is there. Why you were thinking if you that you have to put some other medications to control his BP if you go by only your office BP measurement. So in that is 30% and 20%. That means almost in 50% of patients, ambulatory blood pressure monitoring can help modify and can help you whether the patient at all needs any extra therapy or not. So far, blood pressure, his blood pressure goal is concerned. So what should be the ambulatory blood pressure monitoring? What should be your goal BP? So I have already said, and I have shown you one slide that so far the office BP is concerned, it should be less than 140 by less than 140 systolic and less than 90. If it is above that, it is showing hypertension. Similarly, in ABPM, 24, if you go by 24 hours average, both daytime as well as nighttime as sleep blood pressure, average blood pressure, if it is more than 130/80. But if you go by averaging only daytime blood pressure, it is 135/85. If it is more than 135/85, it is hypertensive. And only by nighttime or as sleep average of nighttime blood pressure monitoring, it is 120/70. So nighttime average, it should be less than 120/70 to be called normotensive, and 24 hours average, it will be more than 130, less than 135/85 according to ISH guideline. And in home blood pressure monitoring, as I have said, it is only possible during daytime. So this is also hypertensive. It would be hypertensive. It is if it is more than 135/85. So home blood pressure monitoring and ambulatory blood pressure monitoring, these two things can predict cardiovascular events better than office blood pressure. And I have already explained why it is being considered more important than office BP. So, and it helped definitely overcome some pitfalls. What are those pitfalls? There, because doctors are also human beings because there could be some error on the part of the doctor so far measurement of blood pressure is concerned. And alerting reaction, that is due to transient secretions of adrenaline whenever patient is entering your chamber, that is called white coat hypertension. So these two pitfalls, but very important pitfalls, and can play a role almost to the tune of 50% of hypertensive patients. So you can avoid all these by going through HBPM or ABPM. HBPM, better medications adherence than ABPM or office BP, because in HBPM patient is actively involved so far measurement of his blood pressure is concerned. So HBPM and ABPM both are very, very important so far reach of goal BP is concerned. But HBPM as patient is 100% actively involved so far medication as so, because for that reason, because of active involvement of patient, better medication adherence has been shown in various studies so far HBPM is concerned. So ambulatory blood pressure dipping, whenever you are going by ambulatory blood pressure, the blood pressure dipping at night can give you a very clinically relevant information. What are those? because you all know during night time, due to the adrenaline secretion is coming down, so dipping of blood pressure during night is quite a physiological uh, variations. So for circadian variations of blood pressure is concerned, physiological nocturnal dipping is quite physiological. So more than 50% of the hypertensive population may show some sort of defects. So for nighttime physiological dipping is concerned, and that is only detected by ambulatory blood pressure monitoring. So there are some patients who don't show any dipping, nighttime dipping, and they are said non-dipper. So BP dipping, according to the BP dipping, there has been categorizations of three. One is non-dipper, another is reverse dipping, and another category is extreme dipping. So non-dippers, normally there is 10 to 20% daytime, 10 to 20% reduction of nighttime blood pressure between 12 midnight to 4 a.m. If it is less than 10%, physiological is 10 to 20%, some books say 10 to 30%. If it is less than 10% daytime, less than 10% of daytime BP, then it is non-dipper. And reverse dipping, instead of 10 to 20% dipping of nighttime blood pressure, it is rise in nighttime BP, that is reverse dipping. And extreme dipping, more than 20%, some books, according to some studies, it is more than 30% dipping at night between 12 midnight to 4 a.m. So is there any problem so far non-dipper, reverse dipping and extreme dipping is concerned? Yes, because you all the time need to have 10 to 20 or 30% dipping compared to daytime average. Why? Because both non-dipping and reverse dipping are associated with more amount of cardiovascular, cerebrovascular stroke or renal disorders. So all these organ-related comorbidities as well as mortalities are increased if patients show through ambulatory blood pressure monitoring they are either being categorized as non-dipper or reverse dipper. And if there is extreme dipping, it is also not helpful. They are showing increased incidence of stroke rates. So these two cartoons I have shown, this is the normal nocturnal dipping, and that has occurred. That is the showing that here the real normal nocturnal dipping that is occurring between 12 to almost 6 a.m. And here that is non-dipper. The curve should have been there, but it is going through there, so they are non-dipper, and that is happening between that is midnight to within 8 a.m. So for this morning, that is early morning dipping, just the reverse thing occurs whenever we get up. After getting up at morning 6 a.m., that there is steep rise in blood pressure as well as pulse rate. That's why it has been shown in various studies that there is 49% increment so far the cardiovascular or cerebrovascular accident is concerned. So compared to the rest of the hours of the day and night. So that's why the NICE guideline has said that we definitely require blood pressure, ambulatory blood pressure monitoring for proper diagnosis, classification, and management of hypertension. They have put forward in 2019 that this is a must for those patients who can afford ABPM. So if clinic BP is between when you should go for blood ABPM, I have already said you all the indications of going for ABPM. If clinic BP pressure between 140 by 90 and 180 by 20, you should definitely go for ABPM along with other guidelines I have said. If you don't go for ABPM, or if the patient is not being able to afford that ambulatory blood pressure monitoring to know in a confirmed way whether patient is really has reached the goal BP or really within the normotensive range before starting therapy, I think it is very important, and the greatest challenge to all the doctors in the management of hypertension whenever patient is considered to be hypertensive in your office clinic, what could be the greatest challenge? Can you guess? The greatest challenge, if you don't have the help of ABPM, is when to begin treatment. So far, this discussion is concerned up to this level, you are really, and we are really thinking that ABPM could be a very important tool, or HBPM. If ABPM is not possible, HBPM is much cheaper compared to that, because patient will only need to have one automated electronic blood pressure measure, blood pressure device or machine. So when to begin treatment is really a greatest challenge for physicians, whether when to start therapy. So far, take home message is concerned, hypertension, I have already said that it's a slow silent killer. Why silent? Because majority of hypertensive patients are asymptomatic, and only 10 to 15%, I have said, less than almost average, on an average 12.5% of 100 hypertensive people, even in UK, are adequately treated and adequately controlled. And hypertension, if we can treat the hypertension of the patient in a proper way, we can have mammoth benefit just by reducing his or her BP to reach the goal BP, and we can achieve 40% reductions of CVA, 20 to 25% reductions of MI, relative reductions of course, and more than 50% reductions of heart failure, and 21% of all cause mortality reductions just by controlling hypertension only. Forget about the other associated comorbidities. Ambulatory blood pressure monitoring really playing an immense role and helps modify decision whether patient is to be initiated therapy or patient needs more drugs for proper control of BP, and it is going to be clinical decision making in almost to the tune of 40 to 50% of so-called hypertensive patients in office BP. Now, white coat and masked hypertension, not uncommonly seen in clinical practice. White coat hypertension almost to the tune of 30%, and masked hypertension is being seen almost to the tune of 11% of 100 hypertensive patients that is coming to your chamber. So that is the most important point to be kept in mind before going for treatment of a patient for hypertension. Masked hypertension I have already said, unlike that of white coat hypertension, masked hypertension definitely carries increased cardiovascular risk. ABPM and HBPM really has gained ground so far in last 1 or 2 decades. So far, optimal diagnosis and management of hypertension is concerned. Hypertension, home blood pressure monitoring being cheaper than ABPM, so it could be more available for mass level, but ABPM can be used in selected more complex conditions for better averaging of blood pressure, because it will make you, it will definitely be also give you some idea about nocturnal beeping and 24 hours average BP. Thank you for your patient hearing.
Thank you very much, sir. As Professor Jyotirmoy Pal sir has instructed me, because he has some emergency work now, so I have to moderate the session for future of this particular event. So I am really thankful to sir, and it is always a great experience to hear from you, sir, learn from you, sir. So now, as we are running short of time, we'll take question in the chat box, and at the end we can discuss some of the questions. And now we requesting our rather second speaker, who is now going to take the fourth topic, that may I request Dr. Goyel, Vivek Goyel, who is an eminent nephrologist from New Delhi. So may I request you to start your session, please.
Good evening, respected teachers, and good evening, Shambo. Thank you very much at the outset for inviting me to speak here. And let me correct it. I'm not an eminent nephrologist yet. I'm still a student of nephrology. And it is my pleasure to speak before Karmakar sir, Jyotirmoy Pal sir, Satinath sir, who have all been my teachers. I still remember till very, I mean, I used to go to Satinath sir's OPD and to learn endocrinological difficult cases from him. So it is a great pleasure, and would begin my presentation now. So the topic that has been given to me is hypertension and CKD. To my benefit, most of the things have already been discussed with respect to hypertension by all the eminent speakers. So I will strictly try to follow my domain of CKD. Well, CKD, as we know, is defined as a kidney damage for more than equal to 3 months due to maybe a structural cause or a functional abnormality, or a GFR of less than 60 ml per minute per 1.73 meter square body surface area for more than equal to 3 months. Now, renal disease is both a cause and a complication of uncontrolled hypertension. Hypertension prevalence increases with declining renal function, and the prevalence of resistant hypertension increases as GFR decreases. Now, the approximate prevalence of CKD in India is 800 per million population, and the incidence of end-stage renal disease is approximately 150 to 200 per million population. Hypertension has been so prevalent that it has been found in almost 65 to 95% patients of CKD, varying from stage 3 to 5. The relationship between hypertension and CKD is cyclic in nature. Uncontrolled hypertension is a risk factor for developing CKD and is associated with a more rapid progression of CKD, and is the second leading cause of ESRD in the United States. Now, hypertension is a risk factor, a cause, a symptom, and a complication of CKD. We can see, so there is a vicious circle that we eventually do not know whether the egg came first or the chicken came first. So whether it was a hypertension that led to CKD, or whether it was a CKD that led to hypertension, because in very many cases, one diagnoses a patient when he's already has reached an advanced case of CKD. So CKD leads to glomerular and interstitial damage, which leads to progressive sclerosis, causing hypertension, and hypertension also causes the above two. Now, this is the GCA classification of CKD by the KDIGO. KDIGO is the Kidney Disease Improving Global Outcome, that is an international organization that deals with the kidneys. And we have seen that it has divided the CKD on the basis of GFR into 5 stages, that is G1 to G5, and on the basis of albuminuria into A1, A2, and A3. Previously, we used to call them microalbuminuria and macroalbuminuria, but now the terms have been changed, and now we refer to microalbuminuria as moderately increased albuminuria, and macroalbuminuria is now referred to as severely increased albuminuria. So this is the KDIGO GCA classification of CKD. Now, CKD is considered as a coronary disease equivalent, because the cardiovascular, the most common cause of death in a CKD patient is a cardiovascular cause. And cardiovascular survival is almost directly related to a person's kidney function. Now, what are the factors that cause raised blood pressure in a patient of CKD? Now, so the well-known factors are, of course, the sodium and the volume excess, the activation of the renin-angiotensin-aldosterone system, the sympathetic nervous system hyperactivity, the renovascular disease, and the arterial stiffness. The other important factors are the mineral bone diseases. It causes a disequilibrium in the calcium phosphate and the parathormone metabolism, causing stiffness of the vessels and causing increase in the afterload. There are decrease in NO and increase in the endothelins, increase in the oxidative stress, whereas other factors like drugs that we use in CKD, very commonly we use erythropoiesis stimulating agents, that is erythropoietin, and which are very notorious to cause hypertension in CKD. That is why we always target a hemoglobin of 10 to 11 in CKD on dialysis patients. We do not target a higher hemoglobin, because targeting a higher hemoglobin would mean higher cardiovascular and neurovascular morbidity and mortality, because they could even cause strokes. Yeah, so the pathophysiologic mechanism of hypertension in CKD is again multifactorial. It is basically the reduced nephron mass. It causes decreased sodium excretion, which causes sodium retention and volume retention. This causes increase in sympathetic overactivity, which again increases sodium retention. The decreased glomerular mass causes increased renin production, angiotensin 2 production, which causes peripheral vasoconstriction and again sodium and water retention. Also, CKD being an inflammatory disease causes endothelial dysfunction, which again through a multifactorial process causes increase in the systemic blood pressure. And what is the maladaptive response to loss of nephron mass? So for that matter, any kidney disease, be it ultimately leads to, according to Brenner's hypothesis, the remaining nephrons try to compensate for the loss of functioning of some nephrons. And there is a compensatory hypertrophy or hyperfiltration. And they try to maximize the GFR, and that causes intraglomerular hypertension, which causes mesangial cell expansion, podocyte injury, which causes a secondary focal segmental glomerulosclerosis that leads to proteinuria and hypertension. Now, there are some drugs that we often use in CKD that can cause hypertension. Erythropoietin, I have commonly mentioned. Now, in India especially, a lot of indigenous medicines are used by patients, a lot of herbal medicines, Ayurvedic medicines, so to say, for to retard the progression of CKD. But as we know, CKD is an irreversible progressive disease. So these herbal and the indigenous medicines often affect the tubulointerstitial compartment of the kidney and can hamper the kidney function. Also, in renal transplant patients, the most common immunosuppressant agent is used is the calcineurin inhibitors, be it the cyclosporin or the tacrolimus, which also aggravate the arteriolar vasoconstriction and hampering the CKD progression. Now, CKD also is a very, very major cause of resistant hypertension. Now, what is resistant hypertension? So there are two terminologies, that is resistant hypertension and refractory hypertension. Resistant hypertension is referred to as uncontrolled blood pressure despite the usage of 3 drugs, out of which one being a diuretic. And refractory hypertension is uncontrolled blood pressure despite 5 drugs, out of which includes a thiazide diuretic and a mineralocorticoid antagonist. So CKD is a very, very common cause of both these severe forms of hypertension. Now, if we compare the pathophysiology between resistant and refractory hypertension, the important take-home message would be resistant hypertension is mostly volume dependent and refractory hypertension is mostly sympathetic activity dependent. And resistant hypertension is mostly seen in the in the older population, whereas refractory is said to be epidemiologically seen in more in the younger population. Now, how do we measure the blood pressure in CKD? Now, the treatment of hypertension is obviously based on the clinic or the office BP recordings. Now, they can be inaccurate due to repeated measurements, the diurnal variations has already been discussed by Professor Karmakar. Now, this again, a single recording of blood pressure is just a snapshot and might not be accurate. And different phenotypes as non-dippers, extreme dippers are also recognized. So in order to do this, the best method is the 24-hour ambulatory BP monitoring, that is the ABPM, on which we have already had one entire session. Now, home BP is an alternative strategy, but it is less resource intensive. Now, the 2017 ACC guidelines, they support out of office BP measurement to diagnose hypertension, and and for titration of BP lowering medication in all the patients. So to ensure accuracy, only the validated home BP devices should be used. Also, they describe the anticipated relationship between clinic and out of clinic BP measurements, suggesting that a clinic BP of 140/90 equates to a home BP of 135/85. And to a daytime and nocturnal ABPM values of 135/85 and 120/70 respectively. So we must interpret each of the separate BPs recorded at different places with a judicious eye. Now, coming to proteinuria. Proteinuria, as we all know, is a marker of renal damage. Hypertension causes proteinuria, and proteinuria also causes hypertension. So we must measure proteinuria, that is the effect of kidney damage caused by hypertension, by a simple test that we could do is a urine protein creatinine ratio or a urine albumin creatinine ratio. Of course, the gold standard would be a 24 a urinary protein, but it is not always possible because it's a cumbersome method, and for a patient at home on an OPD basis, it is quite difficult. Now, the BP reduction will reduce the proteinuria, and if you reduce proteinuria, you will slow the eGFR decline, and you will reduce the CKD progression, and you will reduce the cardiovascular disease of the patient. Of course, the RAS inhibitors are the prototypic drugs of reducing the proteinuria, and hence they are considered the first line agents in proteinuric chronic kidney disease patients. Coming to the treatment, well, a lot of the treatment have obviously been guided by the landmark trials that have been conducted, most of which have already been discussed. I will just discuss a few. That is the MDRD trial. Obviously, it showed that basically there were the interventional group, the target map was 107 versus 92, whereas the participants, the eGFR range between 13 to 55. It showed that slowed eGFR decline in the intensive group only if baseline proteinuria is more than 1 gram per day. So basically, in proteinuric patients, the intensive blood pressure control was recommended by the MDRD. But the ACCORD and the SPRINT trials are the reformatory trials based on which the recent guidelines have been based. So SPRINT trial showed that the intensive blood pressure group were definitely, they had a less all-cause mortality, cardiovascular benefit, renal benefit, and every possible benefit, though they did have a few dose-related side effects also. Now, coming to the other pharmacological management, that is the ACE inhibitors and the ARBs, we've already discussed prototypic drugs for reducing proteinuria. Now, in non-proteinuric CKD, some studies have questioned their benefit, but again, it has been seen that they do reduce the blood pressure, and they can also be used in non-proteinuric CKDs. Now, the problem with these drugs is, the major problem is hyperkalemia and rise in serum creatinine. So guidelines suggest that a rise in serum creatinine of less than 30% from the baseline within a week is acceptable. If it rises more than that, then you need to replace the drug. Coming to diuretics. Now, a very, very common problem with CKD patients is volume overload. So approximately 50% population of CKD is subclinically or clinically volume overloaded. So diuretics again form a mainstay of therapy in CKD patients. Now, in non-proteinuric CKD, monotherapy with a thiazide or a thiazide-like diuretic can have a role, and they can be considered the potential for first-line therapy. Also, thiazides are very good in reversing the physiological nocturnal breathing. Firstly, loop diuretics are often used at the higher doses because they depend on the GFR to work at the thick ascent of Henle. So often a combination diuretic and a thiazide or a thiazide-like diuretic like metolazone is used in CKD patients. Of course, mineralocorticoid receptor antagonists like spironolactone obviously will be helpful, but again, they are not that used commonly because of the risk of hyperkalemia. Now, calcium channel blockers. According to me, the most avidly and the most rampantly used antihypertensive, very safe in CKD patients. Both dihydropyridine, non-dihydropyridine calcium channels can be used, but the dihydropyridine is usually the first line therapy. In proteinuric CKD, though they are inferior to the RAS blockade, but you can add them to the RAS inhibitor in proteinuric CKDs to control the blood pressure. The non-dihydropyridines like verapamil, they also have a beneficial effect of proteinuria reduction. Whereas the newer channels, that is the newer CCBs, that is the which block both the L and the N type of calcium channel blockers like the cilnidipine, or we have all the channel blockers like the benidipine, they are also in vogue nowadays. Coming to the beta blockers, now see, because the pathophysiology of CKD involves rise in the sympathetic nervous system, so beta blockers obviously are very, very helpful, though they were not regarded before as a first line drug and still not are, but in CKD patients, they are very good as an add-on therapy to control the blood pressure. especially carvedilol, has been shown in multiple trials to provide a lot of mortality benefit to CKD patients. Coming to alpha blockers, again, as the BP of CKD patients are sometimes very difficult to control, and they might be on polypharmacy, they might be on multiple antihypertensive drugs, and alpha blockers again are, practically speaking, a very common part of the prescription in a CKD patient. Though they have frequent side effects like the first dose effect, they have the postural hypotension and other side effects as well, but with proper counseling, one often uses them in optimized doses in CKD patients. Now, as the diurnal variation is influenced by the time of antihypertensive medications, it has been hypothesized that the evening dose could reverse the nocturnal dipping, could reverse the lack of nocturnal dipping seen in CKD. So it has so chronotherapy is seeming to be one of the very good method of achieving hypertensive control in CKD patients. Now, dialysis. Now, another subset of patients of CKD are the ESRD patients on dialysis. Now, there is a very common, not that common, but there is a complication in dialysis patient, that is a intradialytic hypertension. Intradialytic hypotension is of course a more common version, but intradialytic hypertension is an uncommon but of a grievous, a more serious consequence in CKD patients. Now, there are basically two causes of intradialytic hypertension. If the BP rises in the first half of dialysis, it is usually due to volume overload. So for that, we just need to increase the ultrafiltration volume and the patient improves. But very often we also see that the blood pressure increases in the second half of the dialysis, and that despite having removed a significant amount of fluid, their blood pressure seems to touch the sky. And then that the pathophysiology behind that is advocated to be adrenergic hyperactivity. And in such patients, a beta blocker, especially with a dual property like carvedilol, is a lot of gives a lot of benefit, and it has been shown in trials that intradialytic hypertension, particularly in the second half, the drug of choice is carvedilol. Now, coming to the next subset, that is the renal transplant patients. Now, renal transplant recipients are again at an increasing risk of hypertension. Why? Because of mainly the immunosuppressants, that is, we use steroids in them, we use calcineurin inhibitors in them, both of which cause hypertension. There could be graft renal artery stenosis, which causes increased RAS activity. The graft dysfunction itself predisposes it, and other donor factors. If the donor is a aged person of above 50 years of age, it predisposes to hypertension, and so on. So how do we control blood pressure in a renal allograft recipient? Now, none of the BP guidelines clearly tell you what to do there, but we need to understand that we have to treat them just like other CKD patients, but we have to take care of the side effects, because the drugs can interfere with these immunosuppressants. For example, the non-dihydropyridines like diltiazem can increase the plasma levels of the CNIs due to inhibition of the CYP3A5 enzyme. So they are often avoided to control blood pressure. Again, we use the calcium channel blockers, and the RAS blockade can also be used, but generally they are avoided in the early post-transplant period, because again, using them raises the creatinine, and then one can be confounded whether it's a graft rejection or it is due to RAS blockade. So the management of hypertension in a nutshell would be, if it's a proteinuric CKD, we always prefer ACE inhibitor ARB. As an add-on, we add a CCB. If it's a non-proteinuric CKD, we could use either ACE inhibitor ARB, calcium channel blocker, or a thiazide-like diuretic. And then if the blood pressure is not controlled, we can keep adding the therapy, but it is preferable to add a different pharmacological drug category to control the hypertension. So it is wise to target the different pathomechanisms of hypertension. Now, very recently, in fact, just 3 to 4 days back, the KDIGO has released its 2021 hypertension guidelines in CKD. So just a small discussion in a nutshell. KDIGO states that office BP measurement is preferred compared to routine office BP measurement. I mean, standardized office BP measurement is preferred compared to routine office BP measurement. And out of office BP measurement with ABPM or home blood pressure monitoring can be used to complement the standardized BP measurement. So the best method to diagnose hypertension in CKD patient is standardized BP measurement. Now, how do we measure them? It may be measured by an automated oscillometric device or manually by auscultatory method. But the preferred device is an automated oscillometric BP device, which is a standardized device. But the main emphasis is on the importance of measuring according to the recommended procedure. Now, manual BP can be measured both with aneroid or mercury, but again, they require regular calibrations. And of course, mercury is preferred over aneroid because it has to be calibrated less often. Coming to the word routine office BP measurement, that basically means where we've not followed the protocol, where we have not followed the directions that have been given by the KDIGO. So KDIGO gives a checklist as to how to measure the standardized BP measurement in office of a patient. That is, we need to make the patient perfectly relaxed. His bladder must be voided. He must not have consumed caffeine or must not have exercised in the last 30 minutes. The technique must be at perfect. The cuff must be of adequate size. We must measure in both the arms. We must release the cuff very very gradually, and so on. And we must take an average of more than equal to 2 readings on more than equal to 2 occasions, and then estimate the mean blood pressure. So this is the proper scientific standardized method. Also, KDIGO recommends lifestyle modifications in CKD to reduce blood pressure. So KDIGO states that a CKD patient must consume less than 2 grams per day of sodium, which is equivalent to 5 grams per day of sodium chloride. It also says that the CKD patient must undertake a moderate intensity physical activity for at least 150 minutes per week, or to a level compatible with their cardiovascular or physical tolerance. Now, blood pressure, what is the drug to be used in CKD patients with or without diabetes? So KDIGO states that whether the patient is diabetic or not diabetic, if the proteinuria is of the grade A2 or A3, by A2 or A3, I mean it is more than 30 milligrams per day, or the ACR is more than 30 milligrams per gram of creatinine, the drug of choice is ACE inhibitor or ARB. Better not to combine them because they can lead to severe side effects. Now, the previous guidelines, including the KDIGO 2012 guideline, it recommended more aggressive lowering for albuminuria than without albuminuria. Because here in the 2021 guidelines, the stark difference that they have made is they have made the target systolic blood pressure less than 120 mmHg, which was not the case in the previous guideline. So they have made it more aggressive. Of course, this is the aftermath result of the sprint trial. Now, they with the adoption of SBP less than 120 for all patients with CKD, irrespective of them being proteinuric or non-proteinuric, everybody must have a target of less than 120. And there are no separate targets for albuminuric or non-albuminuric. So the effects of intensive SBP lowering are in accordance with the ACCORD and the sprint trial. In ACCORD, which had few CKD patients, there were no difference in progression to ESKD between the intensive and the standard SBP groups, whereas the sprint trial excluded patients with proteinuria more than 1 gram per day, and the baseline albumin creatinine ratio was only 13 milligrams in the CKD subgroup. Now, so what are the new changes into 2021 guidelines? The remarkable changes are that they have adopted a standardized office measurement as the preferred technique, which was not the case previously. They have adopted a lower SBP target, that is less than 120, and adoption of the same SBP target irrespective of the presence or absence of proteinuria, presence or absence of diabetes, presence or absence of old age. And mind you, there's another very important thing is that they have only given a target of the systolic blood pressure and not of a diastolic blood pressure. Now, other guidelines which already have been discussed, the 2017 ACC-AHA guideline, they offer a target of less than 130 by 80 for CKD patients. The European Society gives a target of 130 to 139. The NICE gives a target of 120 to 139. So it is only the Hypertension Society of Canada that gives a systolic blood pressure target of less than 120. So the KDIGO 21 is only in line with the Canadian guidelines. These are the JNC 8 guidelines, which already have been discussed, which obviously had different targets for different age groups, and for CKD, which was proteinuric and non-proteinuric, similarly in the other guidelines as well. Now, in the renal transplant recipients, KDIGO states that the target blood pressure is less than 130 by 80, and it states that you can use a dihydropyridine CCB or an ARB as a first-line antihypertensive for renal transplant recipients. Coming to pediatric CKD patients, KDIGO 2021 suggests that the 24-hour mean arterial pressure by ABPM must be lowered to less than 50th percentile for age, sex, and height, respectively. So, in conclusion, the take-home points would be the lowering blood pressure in CKD slows the progression, reduces the cardiovascular disease. We must understand the pathophysiologic mechanisms before treating it. Only then we'll be able to add the correct add-on drug. Existing guidelines do not offer a consensus on the target, but we must do it on an individual basis. And one size does not fit all. So we must always do an individualized treatment of hypertension in a CKD patient. Thank you very much for the patient listening.
Thank you very much, Dr. Vivek Goyel. This is Dr. Tripathi, and it was really a great summary of overview of hypertension in CKD. And I'm sure all the listeners in this audience, they must have appreciated and they must have enjoyed the talk. There might be a few questions, but then for paucity of time, we would request you if you can stay back. At the end, if time permits, we can pick up those questions. It's already, I think we are going late. And so again, thanking you, and then we can go to the next and I think the last in the series of lectures today will be delivered by Dr. Shambo Samajdar, who is a clinical pharmacologist by training, and he is also a practitioner, and particularly his area of interest in clinical practice is diabetes and allergy, etc. But of course, today he will be talking with us, sharing his knowledge and expertise in the area of clinical pharmacology, and he will be sharing his thoughts with us. The title of his talk is Treatment Adherence and Round-the-Clock Blood Pressure Control. Of course, major part of it has been already covered, round-the-clock blood pressure control. But let's hear from Dr. Shambo Samajdar about the clinical pharmacological considerations of this theme. I would only request Dr. Shambo to please be brief because we have been running late. Over to Dr. Shambo, please. Thank you.
Thank you, sir. Thank you for Inovocare for giving me this opportunity to sit with a galaxy of speakers. So hope, as I am talking at 10 p.m. In India, so we will face definitely an adherence problem with our respected delegates to this e-Symposium, but I try to finish by another 20 minutes. So it is important to give emphasis on adherence, specifically while treating the hypertensive patient, because it was shown in various studies that high adherence to antihypertensive medication is associated with higher odds of blood pressure control, and non-adherence to cardioprotective medication increases a patient's risk of death from 50% to 80%. And if we go by the medication adherence, by the numbers, as we are also seeing our participants number was initially it was around 50 and now it becomes 25, and at the end I hope that there will be at least 10 or 12 participants, delegates will remain with us. But see this decline graph of every prescription written, only 50 to 70% of those prescriptions went to pharmacy, and 48 to 60%, 66% come out of the pharmacy, and 25 to 30% are taken properly, and 15% as refilled. So we can see the decline, and this is a data from a developed country, that is USA. So you can assume what will be the impact of adherence in developing countries like India. So in this cartoon, we can see the prevalence of hypertension, that increase in low middle income countries, whereas surprisingly the high income countries, there is some decline in hypertension prevalence. Awareness, it is only 30% around low mid income countries. It is increased by around 5% by 2010. But the important thing I just want to mention here, one point to focus here, that is the controlled hypertensive patient is only 8% in 2000, which was declined in 2010, and it is becoming now 7%. And control among the treated, that percentage also surprisingly, it was 2000 in low middle income countries, it was around 34%, whereas it is declined in to 2010 around 7%. So this is a critical area we need to focus. And one of the major cause of this decline is most probably we are missing those patients due to non-adherence. And two major factors that contribute to hypertension controls in treated patients. Number one, the prescription of an adequate number and dose of prescribed BP medications. And number two is the adherence with the therapy. And we are going to talk about adherence. Just a few interesting numbers. As we can see that adherence to antihypertensive drug therapy reduce the risk of cardiovascular outcomes by 37%, reduce the risk of hospitalization because of heart failure, 20% risk of cardiovascular disease, and 38% lower risk of all-cause mortality. So we are not surprisingly just seeing the slides. You may think that we are going to discuss about some GLP-1 receptor agonist or SGLT2 inhibitors. No, we are talking about only adherence to antihypertensive drug therapy, which has the capacity to reduce this much of bad outcome. And it has a significantly lower rate of major adverse cardiovascular events, both in patients with cardiovascular disease and patients who has post-myocardial infarction. But what is seen actually, a meta-analysis that suggests that adherence to drugs that prevent cardiovascular disease was only 57% after 2 years, and 1/3 of the myocardial infarction patients being non-adherent after 2 years. So this is very interesting and very sad context. So what is adherence to long-term therapy? As per WHO, the extent to which a person's behavior to take medication, to follow a diet, and or to execute lifestyle changes corresponds with agreed recommendations from a healthcare provider. So this is very important, and always adherence is not just equal to compliance. In compliance, there is nothing as patient's agreement to the recommendations, but adherence is included the patient's agreement. Here, the patient is active partners with health professionals in their own care. In broad sense, we can say, in case of adherence, doctors or healthcare professionals plays the role of a coach, and the patient take the role of footballers. So we need to coach our patients to increase the adherence. So I am just giving a few examples before moving directly to the topic, that a 56-year-old lady who came to us, hypertensive for 12 years, diabetic for 10 years, BMI was 29 kg per meter square, admitted in hospital with acute myocardial infarction. Now you can see the medication history. she was on a fixed dose of combination of amlodipine 5 plus hydrochlorothiazide 12.5 milligram, telmisartan 80 milligram, ecosprin 75, empagliflozin 10 milligram, sitagliptin 50, metformin 2 gram, and atorvastatin 20 milligram. What happened in the admission blood pressure? It was 190 by 102. Random CBG was 348. So her diabetes and hypertension is totally uncontrolled. HbA1c is around 8.9%. So after that, we get the last visit data, and we found that the HbA1c was 6.9% with the same medications. Blood pressure was 130 by 80 millimeter of mercury. 6 months back, this is the data, and she was lost to follow up after that. But while taking history, we found that last 3 months after her husband's retirement, she is taking irregularly those costly drugs. So it is important always to understand the importance of adherence. In this type of example educate us about the importance of adherence. So again, another case, a 76-year-old man, hypertensive for 25 years on amlodipine 5 milligram, enalapril 5 milligram, hydrochlorothiazide 12.5 milligram, came to the OPD. The BP was 160 by 84 millimeter of mercury. So what happened? He was added with amlodipine 5 milligram, one extra dose, and as he has a BHP, the tamsulosin was changed to prazosin 5 milligram at bedtime. So again, after 1 month, came to the OPD. The BP was that much, 160 by 78. Adherence was checked. As he was asked to bring all medicine strips. Now we came to know that he is not taking that amlodipine, enalapril, and hydrochlorothiazide for last 5 days because he is getting medicine from the OPD, and as there is a gap of 5 days, he is not and the drugs finished, so he is not purchasing the drug from the their pharmacies. So he is totally dependent of the hospital pharmacy. So what happened? We also inquire what happened. Even if the last time when he came with a BP of 166 by 84, that time also she told, now he told that I am not taking medicines for last 3 to 4 days like that. So as we are without checking the adherence, we just give some extra doses of amlodipine and tamsulosin was changed to prazosin. This particular gentleman give history that last 1 month he felt very weak, maybe due to hypotension, and one episode of fall at midnight when he went for urination. So we had just replaced tamsulosin to prazosin that may cause postural hypotension. So it is always important to ask the patients regarding the adherence, and these are a few important questions while we are seeing hypertension patients, specifically to check whether the patient patients have a good adherence. So number one, how long you have been taking your pills? Are you aware of their benefit and why are you taking them? Show me your treatment. How do you take your tablets? So now you are on 10 tablets. How do you manage? During the last month, how many times have you not taken your tablet? When you take your when you would like to take your pills, or when is the most suitable time for you to take your pill? So this type of question engage your patients, and for that this type of question generally from your side gives some more confidence to the patient, and the timing is very important because some patient, if we just write down 10 a.m. you take amlodipine 5 milligram, some patients sometimes it is important to note that in morning time when they are going to some work, they sometimes forget to take that medicine. So just asking this type of question, if we just change the time of intake of amlodipine, that can increase the adherence. This type of question is again very important, that when could you find time to take your medicine? What could help you change or improve the way you take your medicine? So this type of answer can give us to improve adherence. So there are some factors patient-related factors associated with poor adherence to antihypertensive therapy. We need to know these type of factors, because if we know these type of factors, we can target those factors and we can improve adherence. Number one, it is as hypertension does not cause any symptoms, so it is often seen the adherence to the antihypertensive therapy is little bit poor. Lack of understanding the disease and of treatment needed. So what is the outcome of high blood pressure? If we can educate our patient, that may help to improve the adherence. Fear or possible or experienced adverse effects. We need to give confidence to the patient. Actual or perceived lack of treatment benefit. So in terms of outcome, we can educate them. Fear of stigma associated with disease, that also leads to poor adherence. Treatment interference with patient's daily schedule. Outright refusal in some patients. We need to counsel them carefully. The regimen sometimes become complex. Polypharmacy, we all know that is a huge issue, and that leads to adherence problems. High pill burden, that means sometimes we need to in hospital setting, in government hospital setting also, as there is a lack of fixed dose combinations, we need to give separately the amlodipine tablet, telmisartan tablet, hydrochlorothiazide tablet, like that. So now there are some consensus that how for managing hypertension, it is better to use some single pill combinations. So forgetfulness, comorbidities including depression is very common with elderly population, and physical impairments or cognitive impairments are there. There are some socio-demographic factors, just like our first patient we show here, that she had some problem with their financial things. So there are some practitioner related factors also. Physician inertia, inadequate prescription or regimen complexity, lack of guideline knowledge, lack of training for hypertension treatment, communication skills, patient provider relationship, and most commonly the time constraints. We only found only 1 minute to see one patient in our busy hospital days, hospital OPDs. And obviously there is some healthcare system related factors with poor adherence to antihypertensive therapy. This is common in all countries. Access to care, medication cost, and affordability, which is very important for us, India, when we are generally out of pocket expenditure for our healthcare facilities. We are providing, we are giving our out of pocket expenditure. Guideline inertia, sometimes overcomplicated guidelines. So many guidelines are there. Which guideline we should be stick? They are only in previous speakers have mentioned beautifully about different guidelines. So we need to stick with one guidelines at least. And there are some barriers to the use of single pill combinations. Just like in our hospital setting, we not found any single pill combinations. So how to detect non-adherence? It is important to detection of non-adherence. The suspicion should be there when there is a suboptimal BP control. Just like in the second case, the 76-year-old man, when came to our first visit with that high BP, we should suspect that time the non-adherence. Despite that, we just added some medicine, which may lead to some atrocities to the particular patient. Then the subjective assessment of adherence, that is very important, either on the practitioner's perception or the patient's self-report. But it is important to mention there are some studies done in USA. This type of subjective assessment of adherence is associated with 40% wrong assessment. So subjective assessment sometimes becomes wrong. So we have to be very careful. And the problem is that all the different complicated tools to measure adherence is generally needs some fees to take those help of those tools over the internet. And also those tools are more specific to the clinical trial or clinical research studies, but not that much translated to the clinical practice. Only there is one Morisky adherence questionnaire, 4-item or 8-item, which is much more closer to the day-to-day clinical practice. There are some objective methods also, though it is very difficult to measure in India. that pharmacy refill records, because it is not possible in maximum hospitals in our countries except some CGHS facilities. Pill counts or some electronic monitoring devices. So this is now a demand, hourly demand, to have some electronic monitoring devices and pill counts, which can help us to objectively measure the non-adherence. Otherwise, we can also directly measure the non-adherence by using directly observed therapy, but it is a very costly affair. We need to see one patient in a daycare setting. The nurse should be there. She will give medicine and hourly take the blood pressure measurement, and again she will introduce medication and see the outcome of the therapy. So it is a very costly affair. Digital pills is there, and some biochemical detection of medications in blood or urine by different technologies like HPLC or some LS or MS like that. What is that digital pills? I am just showing one picture on that. This is one thing, that is medication electronic monitoring system. This is available in Europe or America, but we are very much fortunate that one of the organizer in this particular meeting, Mr. Rohan Tripathi, who is a device scientist, we can say, with help of the government of India, some project. He is making some machines now to see the adherence. So in this, we can understand how much tablets the patient is taking, and at the time when the patient needs medication, this type of device will make one alarm, and that help the patient to take the medicine. But this is a very costly thing, 100 euro. I hope that in India we will get a very cheaper this type of devices for our poor patients. And this is one digital pills. That means it has some devices in this type of pills. There is some small chips which, after getting dissolution in our stomach, that chips becomes activated, and we will found in our mobile that this pill is taken. So this type of concepts are there, but they are very much costly affairs. Otherwise, how we can improve adherence? Number one, assess each patient's needs and offer individualized solutions. So we should have some personalized solutions. Make pill taking easier for the patient as per the patient's choice. We have to improve the patient practitioner communication in a blame-free environment. We should not blame, we should not shame. So that is a very important mantra to improve adherence. We have to educate patients, offer motivational interview, involve patient in decision making. We have to empower the patient, implement the guideline recommendations. The single pill combination use is very important, and we should establish a collaborative team-based care approach. Just an example, what we are providing in School of Tropical Medicine, clinical pharmacology OPD, we try to improve adherence of our patients when they are referred to our clinic. Just like I know today, Dr. Shabnam Ara Begum is also there, and Dr. Abhijit Ganguly is also there, who are running their therapeutics clinic in Archicor Medical College. So they are also trying to do some this type of approaches in their OPDs. Use reminders. We need to increase awareness about those reminders, and that should be financially acceptable for our population also. And e-health technology is a very important supportive tool. Now, how to have a 24-hour actions? The ESH guidelines, they recommending we have to start with if the blood pressure is systolic blood pressure is more than 150, then we should start with the combination drug, 2-drug combination. So that dual combination should be in one pill. So they are promoting, all the other bodies promoting to use single combination pills or fixed dose combination drugs. So if we can use those drugs, how we can improve adherence? Because it will decrease the number of pills. So physicians can move from double combination to triple combination with a swift transition, and benefits motivates physician to use single pill combination are number one, that meets the treatment challenges and minimize the risk of treatment failure by increasing the adherence. And how we can make a perfect 24-hour BP control? We have to give emphasis on 24-hour blood pressure reduction, along with the taking care of that blood pressure triad, which is beautifully described and taught by Professor P.S. Karmakar sir, how to acknowledge early morning BP surge, nocturnal BP, nocturnal dipping, and blood pressure variability. And for that, the drug, the antihypertensive drug, should have a long half-life, because if we have a longer half-life, that gives some gradual onset and slower offset of action, which gives a longer duration of action. It gives a greater therapeutic coverage, decreased loss of BP control despite missed dose, because they have longer half-life. So they take much more time to get wash out from the body, and it increases the adherence rate, resulting in improved efficacy and long-term clinical outcomes, because they are mostly once daily dose. And if we go by different classes of antihypertensive drugs, and we can see from SE inhibitor, the perindopril has a 17-hour half-life. Among the ARB, the telmisartan has a longer half-life, like 24-hour. Amlodipine from CCB, it has a 30 to 55-hour half-life. Among the beta blocker, the bisoprolol and nebivolol has a longer half-life. In case of diuretics, chlorthalidone has a 40-hour half-life. So these drugs can attain, or we can say this drug, if we can use once daily, that can take a control of blood pressure over 24 hours. So what is sustained action of antihypertensive therapy? This is generally measured as in terms of smoothness index. So what is that smoothness index? The change in blood pressure from 0 hour to 24 hour after administering one antihypertensive drug, divided by the standard deviation of change in blood pressure in each hour. And if the smoothness index is more than 1, that drug will act throughout 24 hours. They have a large consistent BP reduction. And if we can see one study that which drug has higher smoothness index or near 1 smoothness index, we can found that the amlodipine in 5 milligram dosage, both for systolic and diastolic blood pressure, and telmisartan 80 milligram dosage, they have a more than 1 smoothness index, whereas the telmisartan 40 milligram dose also has around 0.9 smoothness index, along with the valsartan 160 milligram. So another important issue which determines the sustained action of antihypertensive therapy, that is the trough by peak ratio. What is that? It is an index of how well the antihypertensive effect is sustained over the dosing interval. It is generally calculated that trough BP, that means the blood pressure decrease at end of the dose interval or the before the next dose. And what is the peak BP? That means the BP decrease at the peak drug effect. So this, in this case, if we can see here, the right-sided picture, the trough BP, and this is the peak BP. And here in this particular drug, the trough by peak ratio is around 33%. But if the trough by peak ratio is less than 50%, those drugs should be given twice daily. And if the trough by peak ratio is more than 50%, that drug can be given once daily. And which trough by peak ratio is almost 100%, they will be a true 24-hour acting drug. And for that, if we can see, in case of ARB, the candesartan, telmisartan, they has a high trough by peak ratio. Perindopril, amlodipine, and nebivolol, they have a high trough by peak ratio. Here, I just want to mention one drug that is benidipine, that though we can see here the trough by peak ratio is 87%, whereas the T-hub is only 3 hours or 4 hours. So we have to also see the other factors also. The mechanism of benidipine is like that it has some membrane stain property, and for that it has the trough by peak ratio is increased in case of benidipine, and it may be acting for more than 24 hours like that. So coming to my last slide, the epilogue for adherence is simple. What is the simple? Simplifying the regimen. Then I for imparting the knowledge. We should promote informed prescribing, aim for modify the patient's beliefs and behavior. P for provide communication and trust. L for leave the bias, and E for evaluate the adherence. We have to evaluate the adherence. And another E is very important here, that is the empathy. Totally during our counseling with our patients, that E is very important. In adherence, there is 3 E, and we should add another extra E with that, that is the empathy. If we ask questions carefully to our patients, we will get the answer from them regarding whether they are adherent to the therapy or not. Drugs don't work in patients who don't take them. So we have to give importance to adherence. And I am very much thankful to all that 19 delegates who are still staying with me, because I expect that should be around 10 or 12. Now it is 19. Thank you very much. Over to my professor, mentor, my guide, Professor Shantanu Kumar Tripathi, sir.
Thank you very much, Dr. Shambo. You have excellently covered, and it's a great way of ending your session, and that is the last slide. I really appreciated, and that is that simple. Really, the most important thing in ensuring adherence or is actually to take the patients into confidence. I don't know how many patients, particularly hypertensive patients, okay, many a times I have seen at least that many patients have many misbeliefs also, particularly in hypertension, because they most of the time, almost all the time, there is no symptom. Many a times some patients may start believing that it has been cured. So I had hypertension, the doctor gave me some treatment. For last 3 months or 7 months, I have taken the medicine. I feel all right now. There is no need to continue with the treatment. So many patients do believe, okay, and many a times if they get their blood pressure checked and it is found that it is within normal limits, they forget that it is within normal limits while they are actually taking medicines. So they stop taking medicines. This is one extreme. The other is compliance is poor, but the day when I am going to visit the doctor, I take the medicine. Because if I don't take the medicine, so I'm sorry, the other way around. Otherwise they might be taking medicine off and on, not very regularly, but the day they are going to the doctor, they make it a point not to take medicine, because we did some survey also, and we have found very interesting logic from some patients, that they believe that if I am coming to my doctor and if I take the medicine in the morning, the blood pressure will be otherwise all right. So what the doctor will see? So they don't take the medicine by design. The morning dose they skip while coming and visiting the doctor. So there are many peculiar kind of beliefs of the patient, and it is only possible if you, as a practitioner, when you spend some time, discuss with the patient, many a times that is the simple solution to improve and optimize adherence. It was very nicely covered, and although we would have liked to continue with further discussion, but I am afraid it's already past 10:30. Okay, it's almost 10:40 now. So,
any questions?
Yeah, there must be questions. Okay, Dr. Rai, just a brief comment or question, please.
No. I mean, I was one of the speakers, so I was staying back to answer any questions from.
Okay.
GT
Let's
students
see
or
the
from
chat
anybody.
box. Maybe in just another 5 minutes we can spend.
It's my duty to respond to any questions.
So Dr. Roy, I think, was the first speaker, and he's still there. So if there are some questions directed to Dr. Roy, I invite anyone from the audience. If you have any question, Dr. Roy is there to respond.
Yeah, of course I will. And in the meantime, can I ask Dr. Samajdar a question on his?
Yes, please. Go ahead.
As I wait for my question to come, I have a question for Dr. Samajdar. Well, in all chronic diseases, there is a non-compliance and non-adherence issues. Thanks for clarifying the difference between the two, because in neurology we have got epilepsy, Parkinson's disease. What is the international sort of survey data regarding non-compliance in chronic disease conditions? It's never 100% in my personal practice. The figures may be quite low. So has any study been done to look at epilepsy patients, Parkinson's patients, and any other chronic diabetes, for example? What is the international literature saying about, before blaming Indian patients for not taking their medicines?
Yes.
What's the international study data say?
Sir, there is a very interesting paper which suggests that after myocardial infarction, taking medications for their like antiplatelet, like antihypertensive therapy, the adherence after 1 year it becomes 50%.
Yes, exactly.
It is very, and for hypertension also, if we can put some of the important studies, they also suggest that 40-50% in developed countries, they are the adherence rate after 2 years of diagnosis of hypertension. So this is very important area, and we should be very much careful on this, and that is why we need to spend more time to increase adherence.
Is there any difference in the adherence between injectables and tablets? I'll tell you the context in a minute. I'm quite open about it.
Yes, sir. Always in case of injectable, it was found that the adherence is a little bit better. There are some studies that suggest that if we even in case of, we had also done one studies on, though that is a very small study, that in diabetes patient, the adherence of insulin is much better than adherence to statin. And surprisingly to us is that the adherence to statin is much lower than adherence to vitamin B complex.
Right.
So, and that is very important thing we found.
Dr. Rai and Dr. Shambo, I think depending on the context, it will differ. So if you think of in an inpatient setting, orals versus injections. Okay, so there also in Indian context there has been some survey, unpublished survey, where they have shown that injectables in inpatients, the adherence is very good because it is actually the nurse who comes and push the injection. But oral medications, many a times in Indian setting, the nurse will come and hand over the medicine to the patients. The patients, many patients, they will not take it. Okay, or they will take it selectively. They will take some, keep some more under the pillow, and then forget it, either intentionally or by this thing, they will forget it. So there is a difference between the injectable and the oral, even among inpatients. Now, when you talk of outpatients or in home setting, Dr. Shambo is right that insulin, chances of forgetfulness is less, and when it is oral anti-diabetic, one, forgetfulness, okay, but then if you forget a dose, you tend to take the dose, maybe even if it is delayed, maybe next day you take the dose. The lack of adherence even for the thyroid hormone, it's quite high, okay, which is otherwise supposed to be taken on a daily basis in the morning. Many people, many patients do forget, and then they try to take it, okay, whenever they remember. But unless there is clear message by their prescriber to the person who is taking thyroid hormone So people get confused whether if I have forgotten it in the morning, whether I should take it when I remember or just keep it. Okay, because they have forgotten, they also fear that it could be double dosing also.
Yeah.
So these are otherwise complex issues.
So it's
But then the answer lies in
there's a question, I know.
yeah.
There is a very important question raised by Dr. Chiranjeev Bagchi sir and some other delegates also regarding the isolated diastolic blood pressure. So
Yes.
when the diastolic blood pressure is high, what should be our approach? And there are some other question also by some respected delegates that when there is an isolated systolic blood hypertension, diastolic blood pressure is low. So what should be our approach? May I ask Professor Prof. Partha and Partha Karmakar sir to respond to this question?
Yeah. Yes, I mean, Professor Karmakar can go before me, or if he wants me, I can go before me. Up to
If
you.
you allow me, sir, I can go before you or
Yes,
after you,
please.
whatever.
No. You are the boss. You go.
No, not at all. Okay. So it's a very practical questions, of course, that has been put forward by Dr. Chiranjeev Bagchi and many others. So as it is too late, so I will give you very short answer to these two practical questions. So one is diastolic hypertension. That was the first issue raised by Shambo, Samrat. What is the pattern of hypertension? Because pattern of hypertension from 20 years when it rises, both systolic and diastolic blood pressure rises parallelly up to 55 years of age. So what is Dr. Bagchi has put that question there, whether diastolic blood pressure is to be corrected to reach the goal diastolic BP or not. Yes, definitely diastolic blood pressure, if it is raised, it is definitely cardiovascular or stroke morbidity and mortality is definitely there. So you have to control it. But after 55 years of age, what physiology does inside our body, diastolic blood pressure gradually come down automatically. But the systolic blood pressure, it continues to rise rest of life. So what happens after 55 years, diastolic blood pressure that creates a diverging angle. Patient ultimately from both systolic and diastolic blood pressure, which was both the parameters was raised after 55 years, diastolic blood pressure gradually comes down and systolic pressure continues to rise. So ultimately patient is converted to isolated systolic hypertension in elderly. So that is also very important because when we were students, we were being, Dr. Partha will definitely positively gave his adherence to that, and that when we were student in our time, it was being said you need not put too much importance to isolated systolic hypertension. It is not usually associated with raised morbidity and mortality. But now for last 2 decades, it is being said isolated systolic hypertension is equally important in elderly to be treated. And whenever diastolic blood pressure is low and systolic blood pressure is high, you have to try to lower down the systolic blood pressure. Sometimes it is very difficult to control it to the tune of 140 millimeter of mercury systolic in very elderly person. That time, what Barnwell suggests us that in that time, if you can bring it down to 160, to the tune of 160, you should be happy. Even if you cannot bring it down to that level, but because diastolic blood pressure is coming down to from 65 to 55, something like that, because if diastolic blood pressure comes down too low, it can increase the possibility of ischemic heart disease or infarct or severe event. So in that case, what you have to put attention, you have to put attention to the associated risk factors, not to bring it down to below 160 or 60 millimeter of mercury. Better you give importance to other associated features like obesity, dyslipidemia, hyperuricemia, these factors, and that should be brought into control, and that will do justice to the patient. Professor Rai, if you want to.
No, nothing more to add. Your talk was absolutely an eye opener for me. I learned quite a lot, and I think as a neurologist and as a physician, I don't make a distinction between systolic and diastolic. It's basically the evolution. This particular topic has evolved, as I was saying, and it keeps evolving. And there are, countrywide differences, study-wide differences. So we need basically Indian data, because there's no point, like the Americans are saying, their control of blood pressure among Hispanics, Asians and Caucasians is different, and Black Americans is different. So likewise, North Indian blood pressure and Southern Indian blood pressure is genotypically different.
Right.
So we are trying to have a common standard just for parity, but there will be individual differences. I think unless the patient becomes symptomatic with hypotension, because there is no way of predicting who will have a better cerebral autoregulation, where the diabetic persons will have impaired cerebral autoregulation. We also know that people inside their brains have got more small vessel disease with intracranial stenosis. We don't have too much stenosis in the carotid arteries as the Western populations have. We have more stenosis in the M1 or M2 segments. And if we drop the blood pressure over there, there'll be the appearance of silent watershed infarcts. And I have shared my PPT where I've shown you some watershed infarcts. And plus this discussion about variation of blood pressure through the course of the day, including the night dippers, including the morning surgers. 55% surges equals to 3 times the risk. So it's a very complex issue. We are flying blind, but we still have got to deliver healthcare to prevent strokes, prevent heart failure, heart attacks, kidney failure, and all the rest of it. So we are trying to, this is a complex topic with lots of individual variations. We do not have the technology, even in the best served countries, leave aside where we are trying to deliver, bread and butter service to underserved parts of the world like Africa. India is much better off here. So just to give global care, which is our duty as physicians to provide for everybody in the world, first of all, starting at home, I think we just stick to 130/80 or 140/90, however way we can do it, because there's so many variables that it's impossible to get into a practical discussion. It will have to be a theoretical discussion. So that's my take on it. But I fully second everything that Professor Karmakar has said. He has said it so well. I would very much like to listen to his talk again. It was a lot for me to digest. There's a lot of revision for me about the history of blood pressure and its evolution in the way it's gone. There's a question from me. May I answer with the chair's permission, Dr. Samrat?
Yeah,
from Dr. Chiranjeev Bakchi, he asks to Dr. Roy, how many stroke patients? We are avoiding the use of the word cerebrovascular accident. That's how we learned it, but we have learned to call it all as strokes. Let that be the new term. It's all stroke, because it's not an accident. It's basically, there's nothing accidental about having a stroke because it's preventable. So how many stroke patients do I see because of lack of adherence of antihypertensives? Well, this is a question me and Dr. Samrat can share, because it's very difficult to quantify adherence. But generally, when patients land up with a ischemic infarct or a hemorrhage, most commonly, we ask the patients, we ask for a tablet refill check, and we often find that they have been defaulting on the last supply from the general practitioner. Here in England, you see the GP prescribes a 28-day supply of the medicines. The patient takes it to the pharmacy and gets a 28-day supply. We often find out that the last prescription from the GP, which is maintained in the records, hasn't been refilled for the last 1 month, 2 months. So the pressure is sky high, 230. So it's either a non-compliance issue, or at times, even if the patient has been supplied the drugs, they are not taking it. It's impossible to determine which one it is, and there's a half-life of the drug. Plus, inadequate blood pressure is not such rigorously controlled or monitored by physicians as well. Leave aside, Africa or India or any other country where health resources is scarce. Even in Western countries where everybody seems to have good supplies of doctors to look after them. Even here, blood pressure, if we ask a GP whether he would let a 160 blood pressure run, and it's all white coat hypertension, you see. So they're visiting the GP surgery, and they're of course going to have a 160 blood pressure. Of course, when the patient with a stroke comes to the casualty, he will have a 180 systolic blood pressure. It's impossible to determine what the basal blood pressure is for the individual. So we have a problem. But still, as we have discussed, home and ambulatory blood pressure monitoring to prevent strokes, to prevent hemorrhages long-term would be our focus for the future from a population-based strategy. And the next, so basically, I have seen lots of patients who haven't taken medicines. I have found evidence in some. In others, I've assumed, and I think we should also assume that in some small percentage of cases, we have failed the patient. We have not given them the right drugs in the right doses with the right choices. And compliance is an issue up to 50%, as Dr. Samrat said, in heart attack. So just imagine. And the question about the insulin and the oral hypoglycemics is a personal question. I am trying to understand my own human behavior as to why I like taking insulin every day, but I can often deliberately miss the tablets. And I do not know how I think, why I think. So just asking the question to me, I can't answer it. Imagine doing a trial, Dr. Samrat, on this for the general population. Good luck to you. There's another question. Are they more prone to catastrophic than who are yet to start any antihypertensives? Yes, patients who have been controlled on a good combination of antihypertensives, if they suddenly default on them, then of course all that effect of the antihypertensives is withdrawn. So the cerebral autoregulation goes haywire completely. So I would expect them to have a huge surge of blood pressure, and hence on the fragile arteries that are there in the lenticulostriate, the basal ganglia, the thalamus, the cerebellum, where the spine arteries are, they've already been hammered for 40, 50 years, and their walls are thinned out. They will land up with a bleed. Whereas if somebody is gradually becoming hypertensive, there is a cerebral autoregulation and the intimal thickening and the muscularis getting thickened up to counteract it. So my answer is yes, somebody who is antihypertensive is at more risk to have a hemorrhage if they suddenly stop their drugs, depending on the half-life when the effect starts to turn off. Plus, if they're doing exerting things like having constipation or having intercourse or doing Valsalva, lifting a heavy weight, then they will suddenly wake up with a big hemorrhage. Whereas if so, the answer is yes. Where if you really start somebody on a medicine, they should be counseled, warned that please be careful. If you omit the drug, you are more likely to have a hemorrhage. If you went to Howrah station and was lifting a 20-kilo suitcase, you will end up with a hemorrhage, and that has happened. Or you're shouting, getting excited, in a football and rooting for your team, as happens here. And then they'll end up with a hemorrhage in the football galleries. So yes, so that's the answer to those two questions put to me. Shubhra has asked a question. In ASA guidelines, blood pressure reduction 15% in 24 hours. But you told systolic blood pressure target to 140. Sir, bit confused. Please clarify at Dr. Roy, sir. Yes, Dr. Shubhra, yes, thank you for the direct question. I said the international guidelines say 10% reduction every 24 hours. As you can understand, these are only guidelines, but you have read some American Stroke Association guidelines of 15%. Again, we are not talking about exact sciences. We are asking doctors. I'm following guidelines where I do not want a sudden drop in blood pressure, because that's when patients will start having either infarctions around the area of hemorrhage. I discussed that in my PowerPoint. I hope everybody has managed to pick it up from the chat box. If somebody hasn't, please email me and I'll send the email to you because there's lots of guidelines there. It's for all of us to share, and it was meant for the students to prepare themselves for the real world when you see the patient coming in. Yes, the answer basically is 10% is just to make sure that you don't go down very suddenly and land the patient with a hypotensive stroke in the eagerness to bring the blood pressure down to 130 over 80 or 140 over 80, 90, as we said, because this is a population figures. I may require a blood pressure of 150 over 85 to maintain my mean arterial blood pressure and the cerebral perfusion pressure, because there were three variables at work I did talk about in one of my PowerPoints, where the cerebral perfusion pressure, which is the determinant, which keeps the neurons blood supply going, the MAP, cerebral CPP, cerebral perfusion pressure, equal to mean arterial pressure minus ICP, intracerebral pressure. We are not measuring intracerebral pressure. We are assuming it's normal. Of course not. Cerebral edema taking place. So, and we are not putting in intracerebral bolts to measure the intracerebral pressure. So we are not dealing with an exact science by any stretch of imagination. So you saw how a patient's cognitive state, which is a surrogate marker that they were using to control blood pressure. In my slide on the guidelines of how much blood pressure should we keep in subarachnoid hemorrhage, that was the guideline. Go with the patient's Glasgow Coma Scale, for example, cognitive assessments. If the patient is thinking, talking, responding well enough, you can assume that the perfusion of the brain is sort of satisfactory. But unless we are doing a study with invasive, non-invasive transcranial Doppler, and that will only give you arterial supply to the middle cerebral artery. How will you study the anterior cerebral artery? Because the frontal lobe functions, the executive functions, I showed you the pictures on the brain, middle cerebral, anterior cerebral distribution. So we are trying to save the nation first. And then when the younger generation is ready to do the research, there's plenty of scope for research in all of neurology. You have seen there's only 3,000 neurologists in the whole country. And wherever you go, you will find enough scope for research and development. Pick up any disease, there is 10 different research projects any neurologist can give you to do to progress science. But first of all, you have to treat the population and get them better, because you starts at home to get patients better and cured from common causes. It's a treatable cause. You see, hypertension is treatable. You cannot treat Alzheimer's, you cannot treat Parkinson's, you can alleviate it, but here you can prevent. Because once I have a stroke, then you see I'm a burden for myself, my family, my society. And that was entirely preventable, you see. And I realized that there is only 2 hospitals in the private sector who can thrombolize me in Kolkata if I have a stroke. Now that is really a heartache. And there is only 1 person who does thrombectomy in Kolkata that I know of. Whereas you see, if I have a heart block, coronary artery block, there is at least 100 friends and cardiologists who can open up my coronary arteries. There's a big mismatch in all this. And brain, you see, when you lose brain, you won't get it back. Lots of it is spare capacity, so we can manage. But strategic, thinking, talking. Just imagine if it happened to me, how would I feel? And this is not only in Kolkata or in India, it's all over the world. There aren't enough interventionalists because all these clots that are forming. So first of all, let's prevent the problem. Then in the acute setting, do what we can scientifically, and then secondary prevention. I was given a very interesting and a wide talk. Thank you very much.
Thank you, Doctor. I think it is very interesting, and we could have continued it further, but then I think it's already three hours now. Okay. So, yeah, it's 11 o'clock. So I think it's time that we call it a day now. Okay. Thank you. I hope the few people who are still there, they must have enjoyed it thoroughly. Okay. And it was a great academic feat. And I must congratulate our faculty today, Dr. Roy, Dr. Karmakar, and Dr. Satinath, Mukhopadhyay, and our young friend, and Dr. Shambo. So all of you. And initially, I think Dr. Jyotirmoy was there in the initial few sessions. So it was a great experience. Thank you all for staying with us, and hopefully we'll be again meeting. We have decided to have series of this. We have called it actually Adherence series. Okay, so we'll take up the different therapeutic areas where adherence really bears a significant meaning. So that's how we have chosen hypertension this month, and maybe next month we'll pick up something else which also has important bearing so far as adherence is concerned. With this, I thank you all, and I hand over to Dr. Shambo to have concluding remarks, and then.
Yes, sir. So we will not bother to disturb our parasympathetic nervous system now because it is over 11. But may I request our organizer, Mr. Rohan Tripathi, to say a couple of things, and who is a lead scientist in making a very important device for us, which can increase adherence in our patients. And I hope Rohan will take care of that financial constraints of our maximum of our patients also. So over to Rohan, says the concluding remark.
Thank you so much. We were really encouraged even more to hear so much about adherence, and we were, our faith and our confidence in what we are doing has been increased further by all your enlightened talk. And I thank you all for being a part of this. And one line that Shambo said stays back with me. A lot stays back with me, but I can speak back one line, that is, the medicine won't help you if you don't have it properly. So
Absolutely, absolutely. All right.
So that being said, it's already 11 in India. So all kinds of adherence says that we should end the session right now. So thank you very much. This was the second of our adherence series. We will have 10 more such sessions coming up in 10 months. So hope to have you all a part of it. We feel very bad when we have to stop someone from, we can't let Dr. Roy, really apologize as you were not allowed to,
No. It's not.
finish your
আবার হবে,
entire
আবার
session.
পরে হবে, এখন রাত্রি হয়ে গেছে, সবাই ঘুমোতে যাবে, খাবে,
But
ঠান্ডা হয়ে যাবে, ভাত ঠান্ডা হয়ে যাবে।
I also just raised one small statistics today in Facebook also. Now we are also still live. There are lots of doctors and common people are also watching us via Facebook. So it is very good news, and we are thankful to those Facebook viewers also.
তারা সবাই ভালো থাকুন। For everybody, education is very important for everybody.
So thank you everyone. Hope to have you all together with us the next time and in the future too. So let's end it there. Thank you. Good night.
Thank you.
Good night, everybody.
সবাই ভালো থাকবেন। Stay safe. জয় হিন্দ।
Jai Hind.
Jai Hind.
জয় হিন্দ।